Good morning, and thank you all for attending today's forum called After Newtown, a national conversation on violence and severe mental illness. Today we are here to listen and to learn from those who have lived lives of fear, worry, frustration, love, and compassion. The families of those with children who have violent mental disorders. Since I became the chairman of the Subcommittee on Oversight and Investigations, we began examining mental health resources and programs across the federal spectrum in the wake of Newtown, Connecticut tragedy. As I wrote in the Pittsburgh Post-Gazette on December 30th of last year, the common factor in many mass tragedies is an underlying mental illness. The lessons for Americans from the horrifying tragedy in Connecticut is that we had better take off our blinders and deal with such illness, or we are sure to face the same problem again. It is not only what is in a person's hands that makes their acts violent, it is also what is in their minds. Tragically, over the course of recent history, society has dealt with individuals suffering from mental illness as if equipped with such blinders, a willful ignorance motivated by fear. This has resulted in some shockingly counterproductive and cruel practices to the mentally ill. We've locked them in prisons, we've quarantined them as contagious, warehoused them in workhouses, and burned them as witches. And then 50 years ago, we released them out of hospitals by reasons we mistook for compassion. Too many of them ended up on the streets without decent access to treatment. The majority of mentally ill should be receiving care in a community setting. But for many with severe mental illnesses, deinstitutionalization was a disaster, the after effects which we are still struggling to recover from even today. Now, too many fill our prisons and are left as the wandering homeless. The vast majority of Americans with mental illness are nonviolent and, in fact, much more likely to be the victims than the perpetrator of a violent act. That is why this subcommittee is working to identify precisely what federal resources in support of both research and care are being devoted to those among the mentally ill who are most prone to violence, the severely mentally ill who are not being treated. And even more importantly, what fraction of those resources are actually reaching the individuals. A few years ago, when this committee was reviewing my legislation, the Senior Access to Mental Health Act, which was signed into law in 2008, I explained how healthcare costs balloon when mental illness goes unaddressed. The cost of care for a chronically ill person with untreated depression doubles. Further, untreated mental illness increases the risk of heart disease and other comorbidities. Without integrating the care of the body with the care of the brain, our current system is wasting billions and billions of dollars. Yet, while there have been calls in recent months for the need for increased funding for mental health, and that's something we need to look at, the truth is that annual total public spending on support and treatment for the mentally ill individuals is now more than $140 billion. This is a 14-fold increase over what we were spending in 1963 in today's dollars, when President Kennedy proposed the community mental health centers to take the place of state mental hospitals. This massive increase in funding, even accounting for our nation's growing population, has not been accompanied by a meaningful increase in the quality of mental health services. The crisis we find ourselves in, however, is not just a question of funding. Rather, the current situation demands more intelligent targeting of available funds towards the most promising research and treatments. Funds must reach the level of patient, family, and doctor if they're to be effective. In this spirit, we hope that today's forum will enable us to begin an extended discussion on how to improve our efforts to identify the severely mentally ill early on and assist them and their families in seeking treatment effectively. I want to especially thank the parents who are with us today. Liza Long, who's going to be with us on video teleconference, Pat Milam, and Peter Earley, to share their stories about what it is like to have a child who suffers from severe mental illness or other mental disorder. Pat's son Matt lost his life to his illness, and to Pat and his wife Debbie, I want to extend our deepest sympathies. To each of you, I thank you for taking the time to be here and having the courage to share your stories with us. Your stories today should help other families and hopefully spur action to help save lives. For the members here today, we are here to listen and learn. We will hear real-life stories of what America does not want to hear. A Kaiser Family Foundation study published in February last month noted that 76% of Americans believe the mentally ill experience discrimination. We are here to take mental illness out of the shadows and bring it into the light and find some real, workable answers for serious mental illness, which affects 11.4 million Americans. Now understand, this forum is just the first step. As I said, the vast majority of people with severe mental illness are not violent. This committee is committed to addressing the difficult but necessary question of how we can stop the violently mentally ill from acting out and get them treatment before they harm themselves or others. We will continue to meet with parents, families, and patients who suffer from severe mental illness as we try to make sure that a tragedy like Newtown doesn't happen again. I also want to thank Ranking Member Diana DeGette for her cooperation and support throughout this endeavor. It's a credit to her and her staff that this morning's forum is indeed a bipartisan effort, as the subject matter deserves. And now I'd like to give the Ranking Member an opportunity to give brief remarks on her own.
Thank you very much, Mr. Chairman, and thank you for your dedication and your work for so many years on addressing mental illness. As I was just saying to Mr. Earley, mental illness affects virtually every American family. It doesn't discriminate based on political party, and that's why it's so important that we're all here today talking about this issue. I want to thank all of our panelists for participating today, Dr. Insole and Dr. Kopelwitz, who have been with us before and helping us to understand this important and complex issue. And I also want to welcome Michael Fitzpatrick with the National Alliance on Mental Illness, who's talking on behalf of mentally ill patients and their families. I especially, though, want to add my thanks to the three panelists who are parents of children affected by mental illness, Mr. Earley and Ms. Long. Your children are so lucky to have you advocating for them, and also Mr. Milam and Mrs. Milam, who's in the audience. I express my deepest condolences at the loss of your son, Matthew. I know you did everything you could to save him, and you honor his legacy by being with us today. Mr. Chairman, last December our nation was once again united by tragedy when a disturbed young man slaughtered 20 children and their 6 brave teachers at their school in Newtown. Once again, we came together to ask how this could have happened and what we could have done to stop it. All of us have been there before, but this time was different than all of the others. In the weeks and months following Newtown, we have as a nation begun to engage in a really important and in-depth conversation about our views on violence, on guns, and on how we respond to mentally ill individuals in our communities. As this conversation has evolved, I'm confident that we can find consensus around reasonable solutions on a number of fronts to keep these killing machines out of the hands of disturbed individuals. I think we can all agree there's no one solution, but the tragedies have all revealed significant gaps in many of our systems, including our nation's mental health system. The perpetrators of many of these mass killings, including Newtown and Aurora, which is right outside my congressional district, and Tucson and Virginia Tech, and Columbine, which is actually in my congressional district, were young men suffering from serious mental illnesses or exhibiting behavior associated with serious mental illnesses. Yet they did not get the help they needed, and too many lives were lost as a result. We know that many, actually almost a lot of mentally ill individuals do not receive appropriate treatment because of the stigma associated with these illnesses even now today, or because of shortages of beds for treatment, or simply because they lack adequate health care coverage. The numbers are stark. The typical delay between an initial episode of psychosis and the start of medical treatment is 100 weeks, over 2 years. And for those living with a serious mental illness, approximately 40% did not receive treatment in the past year. Those numbers are just simply unacceptable. Now, I think we need to be clear. Most violent acts are not committed by people living with a serious mental illness. And most people living with a serious mental illness are not violent. But if we can reduce gun violence by improving the mental health care system so that we are more certain of diagnosing and treating potentially violent mentally ill individuals, we can and must do so. Now, we've already taken some steps to solve this problem. The Mental Health Parity Act ensured that private insurance companies cover treatment for mental health and substance abuse. The Affordable Care Act will extend health care coverage to tens of millions of Americans who would otherwise be or underinsured. But I think it's now clear to all of us that we can do more. Mr. Chairman, post-Newtown, this Congress should be focused like a laser on reducing gun violence. Comprehensive improvements to the mental health care system must be an important component of those efforts and will benefit millions of Americans. Thank you, Mr. Chairman, for calling this forum today. I look forward to hearing from our witnesses and our continued cooperation in working on this issue.
I thank Mr. Gett. Mr. Upton, the Chairman of the committee, is recognized.
Well, thank you, Mr. Chairman, and I have a full statement for the record, and I apologize for my voice, getting over a bad cough and cold, but frankly, that shouldn't be a problem because I'm here to listen. Let me just say that you, Dr. Murphy, Mr. Chairman, there's probably no one better qualified with your professional background to chair this subcommittee and examine mental health and the connection to violence. I have no doubts that your partnership with Ranking Member Diane DeGette will indeed thoroughly explore this major issue and topic of the day. In the days following the tragedy in Newtown, Chairman Murphy and I discussed his leadership role and somewhat unique ability with his background to really try to chart a course that indeed can be bipartisan and make a difference in the lives of Americans down the road. And I welcome not only this forum today, but the work that's going to continue to be done in the months ahead, and I yield back my time.
Thank you, Mr. Chairman. The ranking member of the full committee, Mr. Waxman, would you like to make a brief statement?
Thank you very much, Chairman Murphy, for holding this forum and leading the conversation about how we can identify and treat individuals with serious mental illnesses. I commend your leadership on this issue, and I'm pleased to be working with you to educate the Congress and indeed all Americans about mental illness and to craft solutions to the many challenges we face in addressing the needs of those who suffer from these illnesses. I also welcome our panelists, including parents who are here to testify, Mr. Earley, Ms. Long, Mr. Milam. I know how hard it must be for you to share your family's experiences, and in Mr. Milam's case, your tragic loss, but I assure you that we are listening. We must not stigmatize individuals who suffer from mental illnesses as being violent or potentially violent. The vast majority are not. But the witnesses we are hearing today underscore the connection between appropriate, high-quality mental health care and the safety of our communities. We know that there are too many impediments to those living with serious mental illnesses that they face when it comes to getting diagnosed and treated. The Affordable Care Act will help expand coverage, but it won't solve all the problems. There is an unwarranted stigma attached to seeking help for mental illnesses. There are shortages of facilities, beds, and caregivers to provide treatment. Mr. Chairman, I appreciate our panelists sharing their expertise on these issues. I'm looking forward to working with you and others of our colleagues on both sides of the aisle to find solutions to these problems. I like this setup where we're not just Democrats on one side or Republicans on the other. We're seated together to learn together and to work together. Thank you.
Thank you. I'd like to just let the members know what the format will be here. This is not going to be the traditional mechanism by everybody's going to be recognized for a certain number of minutes. We're going to hear from our families. We'll also ask some questions of some of the experts who are here too. And your questions are to be directed towards further data and explanation. We'll hold off on speeches and comments. We will have other formal hearings in the future to get into more of these issues. But this is really a listen and learn session from people who have lived this. Let me introduce some of our panelists who joined us today. First, Dr. Thomas Insole is the director of the National Institute of Mental Health, Bethesda. He was appointed to lead the National Institute of Mental Health in 2002, a graduate of Boston University's medical school, residency in psychiatry at the University of California, San Francisco. Prior to his appointment at NIMH, Dr. Insole was the founding director of the Center for Behavioral Neuroscience at Emory University. His research focused on neurobiology of complex social interactions. Dr. Harold Kopowitz is the president of the Child Mind Institute. Dr. Kopowitz is one of the nation's leading child psychiatrists, a graduate of Albert Einstein College of Medicine, and completed his residency in psychiatry at the New York Hospital Westchester Division. In 1997, Dr. Kopowitz founded the NYU Child Study Center, and he directed the Nathan Klein Institute for Psychiatric Research from 2006 to 2011. Dr. Fuller Torrey, founder of Treatment Advocacy Center in Bethesda, Maryland. He's a research psychiatrist specializing in schizophrenia and bipolar disorder. He graduated from medical school at McGill University and trained in psychiatry at Stanford. The founder of the Treatment Advocacy Center and executive director of the Stanley Medical Research Institute are among his accomplishments. His most recent book, The Insanity Offense, details the ways in which public policy has failed those with the most serious mental illnesses. Dr. Michael Wellner, founder and chairman of the Forensic Panel in New York. He is a leading forensic psychiatrist and has examined numerous surviving mass killers from around America and is regularly consulted to dissect a range of complex cases at the psychiatry law intersection, from Guantanamo to Hong Kong. He developed peer-review protocols for enhancing the integrity of forensic consultation and has pioneered research of evidence-based determination of depravity and crime, including input of the general public at www.depravityscale.org. Next is Pete Earley, a writer, a blogger, and parent of a son with mental illness from Virginia. Mr. Earley is a critically acclaimed author and journalist. He spent 6 years at the Washington Post and has authored 13 books. His book, Crazy, A Father's Search Through America's Mental Health Madness, was a finalist for the 2007 Pulitzer Prize. Crazy recounts Mr. Earley's efforts to get his son effective treatment for bipolar disorder. He works with the National Alliance on Mental Illness to advocate for mental health reform. Next to my right, Pat Milam, mental health advocate and parent of a son with mental illness. He's from Louisiana. Mr. Milam is an advocate for mental health reform. His public advocacy efforts began after his son, who had been diagnosed with schizophrenia and bipolar disorder, committed suicide in 2011. Throughout his efforts to get his son the treatment that may have prevented the tragedy, Mr. Milam encountered numerous obstacles to effective care. And also joining us is Liza Long, a writer, a blogger, parent of a son with a mental disorder, who's joining us remotely from Boise, Idaho. Ms. Long is the mother of a son with a mental disorder, and in the immediate wake of the Newtown tragedy, Ms. Long published a blog post entitled, I Am Adam Lanza's Mother. The post, which is read by millions, recounts her difficulties raising a child with mental disorders. She is now devoted to continuing a conversation on the hardships parents face while caring for a child with a mental disorder. And finally, Michael Fitzpatrick, a social worker who is also the executive director of the National Alliance on Mental Illness in Virginia. Prior to taking the role of the executive director of NAMI in January of 2004, Mr. Fitzpatrick served both as the director of NAMI's Policy Research Institute and the National Policy Director. Before joining NAMI in 1999, Mr. Fitzpatrick held senior management positions in state government, in nonprofit agencies in both the mental health and primary health sectors, and in the private sector. He earned his MSW from Boston College. Let's now turn some of our parents to begin to tell their story briefly, and we will open up from there. First, we'll start off with Pete Earley.
Thank you very much. Thank you very much for having me here today. My son wears the face of mental illness, so I'm grateful for each and every one of you for being here and paying attention to this important subject. Thank you. Dad, how would you feel if someone you loved killed himself? My college-age son, Mike, asked me that question when we were speeding from Manhattan to Fairfax County, Virginia. My son had been diagnosed a year earlier with a mental illness, bipolar disorder, and a doctor had put him on medication. But my son had stopped taking his pills. And when I picked him up that morning in New York, he'd been wandering around aimlessly for 5 days. He was convinced that God had him on a special mission. And during that frantic car ride, my son would laugh one minute and begin sobbing the next. And I pleaded with him to take his medication, and he screamed at me, "Pills are poison. Leave me alone." We got to Fairfax Hospital, Innoville Hospital. I remember the emergency room nurse rolling her eyes while Mike talked gibberish about God having him on this mission. And we were taken into a room all by ourselves, and we were there for 4 hours. And finally, my son said, "I've had enough. There's nothing wrong with me. I'm going to leave." And I said, hang on. And I raced outside, and I literally grabbed a doctor. And I said, "Please come in." And he said, "Look, you seem like a nice guy, but I really can't do anything to help your son. Virginia law at that time was very specific. Unless a person had posed an imminent danger to himself or someone else, he could not be forced into treatment or required to take any help. And my son had told the nurse that he thought all pills were poison. We'd been sitting there for 4 hours. So the doctor said to me, there's nothing I can do. In fact, I was told, bring your son back after he tries to kill you or tries to kill someone else. Well, I took my son home, and for the next 48 hours, I watched him sink deeper and deeper into a mental abyss. At one point, he had tinfoil wrapped around his head because he thought the CIA was reading his thoughts. He slipped out of the house early one morning. He slipped out. He broke into a stranger's house. He broke in to take a bubble bath. Luckily, no one was there. It took 5 Fairfax police officers to get him out. When they did, they took him over to a mental health center, and they called me, and I raced over, and a policeman was waiting outside. He said, Mr. Earley, before you go in there, let me give you a little advice. Even though your son told us he has a mental illness, even though he told us he's off his medication, even though we picked him up in a house taking a bubble bath, unless you go tell that doctor that your son has tried to kill you, he will not meet Virginia's imminent danger criteria, and he will go to jail, and you don't want that. And I looked at him and I said, my son hasn't threatened to kill me, and he shrugged. So I'm here today to tell you, and I do it with no great pride, that I lied. I told that doctor my son had threatened to kill me, and that was good enough to get him taken into a hospital. 24 hours later, our insurance company called. They wanted him out. He was not considered a danger. And then my son was charged with 2 felonies, breaking and entering, and destruction of property. What happened to my son, I learned, was not an aberration. Right now, as we're sitting here, there are more than 400,000 people with bipolar disorder, schizophrenia, and major depression in jails and prisons. 500,000 are on probation. More than 1 million go through the criminal justice system every year. And the largest public mental facility in the United States today is not a treatment center. It's the Los Angeles County Jail. Now, as you've already heard other people say, people with mental disorders are not violent, the majority. But many times those few who are, such as the Virginia Tech shooter and the Tucson shooter, give warning signs, yet their parents are often helpless to stop them because of civil rights laws that sound noble but cause havoc when applied to someone with a brain disorder. I love my son. I want his civil rights protected, but no father should ever be told, bring your son back after he tries to kill someone or kill you. Changing our commitment criteria is a much-needed first step, but it will do absolutely no good if you have nowhere to get treatment. When my son had his breakdown, Fairfax County, one of the richest counties in our nation, had a 2-week wait to get into a treatment center, a 6-week wait to get a case manager, an 18-year wait to get housing if you had a mental illness. That's shameful. Since my son's first breakdown, he's had 3 more major breaks. He's been shot twice by the police with tasers. I hate to admit this, but I will, because it's a common feeling among parents. There was a time when I wished my son had not been born because of how much he was suffering. But today, my son is doing great. He has a job. He lives on his own. He pays taxes. And if he were sitting here before you, you would not know that he has a mental illness. He's one of the fortunate ones who finally, after 9 years, got the meaningful treatment that he needed to recover. So don't tell me we can't help people with mental illnesses. I've seen it. This is not a problem of us not knowing what to do. It's a problem of us just not doing it. All of the pain that he endured, all the pain that my family has suffered, all of the tax dollars that have been wasted, and all of the fear that he caused others could have been avoided. None of this should have happened. Why do we treat the head differently from the body? Why do we treat mental disorders different from other illnesses? We tell our daughters and our sons, oh, you are sick, but we're not going to help you until you become dangerous. And then when they become dangerous, we blame and we punish them. If in that scenario, you tell me, who is the crazy one?
Thank you. I now recognize Mr. Milan.
Hey, Mr. Chairman. Ladies and gentlemen, I'm not a public speaker, and this is going to be tough for me. So I hope you would endure me a little bit to go through this. My wife and I, Debbie, who's here today, have gone through a lot, and I'm going to try to give you an example of just a short period of our life, a 6-month period. I'm going to try to paint to you what the misery's like, what the horror's like. But keep in mind, though, I don't speak just for us today, because I can tell you, through this tragedy since Matthew died in October 2011, everywhere I go, every expert and lay person I talk to, it's like, oh, that's news? We've heard that. My friend did that. I had a friend cut an eyeball out. It's not something that's rare. It is happening out there every day. And I'll point out a few other things that are a little different about me. I like probably most of the people in here are middle class. You know, we have corporate insurance. So it's not a matter of asking for federal government funding for us. We had an insurance policy that we paid every month, and we thought it was there to protect and give the best medical coverage to our son. And if not, we would private pay for that coverage. Just to give you a background, in April of 2011, Matthew was doing good. And then he started becoming paranoid. He started seeing things. And as Pete mentioned, a lot of kids, young men, do see things. They become paranoid. He actually went to his doctor and told his doctor, I'm going crazy. And he had seen a psychiatrist for 6 years. Same psychiatrist. Said, I'm going crazy. I'm seeing things. A few weeks later, he drove himself to the emergency room at the local hospital, walked into the hospital and said, I want a brain scan because my brain is leaking. Somebody whispered to me, a nurse, a while back, that my brain is leaking. I'm dying. And they believed him enough to give him a brain scan. But at the same time, they put him under a PEC, a Physician's Executive Commitment Order in Louisiana, because when the doctors came back, he asked them to prove who they were. I mean, that's just not insane things to do. So he went to see the doctors more and more. He actually went and saw the doctors and made quotes, and I have the medical records, so this is a little unique for me. He had told the doctor he was paranoid. He didn't know what was real. He didn't know if he was living in a program. He thought he was living in a program, computer program. The FBI, the CIA, and the Martians were out to get him. He told the doctors that the aliens from another world were coming to get him, and that we have not discovered who's living under the earth, under the sea, that we should look at that. And he's telling these doctors during these visits all these kinds of things. Other than that, he says he loves life, so they let him go. He tried to commit suicide twice before the last time I'm going to tell you. One time he wanted to go back to a rehab that he'd gone to the year before, and he was doing really well. I can't tell you, kind of like Pete, driving down the highway. We were going back to the rehab he wanted to go to. He was doing fine. He just wanted the comfort there. He swallowed a bottle of pills. Now, I can't tell you the horror it is to have a child behind you going down interstate highway trying to get him to the place to save him. And he tells you, if you stop the car, I'll jump out and kill myself with these trucks behind us. That is a nightmare scenario for a parent to have to live through. We made it that night. But they treated him, and a few weeks later, they let him out. So we think, okay, he's home again. He's home again. We're trying to go back to normal life. We think we've made it good this time. Well, I leave the house for about 5 minutes. Luckily, I was 2 blocks away. A black car drove up in front of the house. My wife, thank God, was having breakfast with Matthew. Matthew immediately saw the black car, went crazy. He went nuts. He didn't know what to do. He went in the bathroom and drank bleach. And then he grabbed a knife out of the kitchen and cut his throat. Luckily, I was 2 blocks away. I got home, and he didn't cut the carotid artery all the way. I ran in the house. Blood is everywhere. And I don't mean to be too graphic, but I want you to know what a parent goes through. I had to chase him down. And as I'm chasing him down, he's telling me, Dad, you don't understand. The more you chase me, the more my heart will bleed, the more the blood will pump, and the quicker I'll die. I was successful in tackling a 23-year-old man, 24-year-old man at that point, and saving him for the ambulance. They took him to the hospital. We saved his life. He lost 2 liters of blood. A week later, let him out. He's fine. They gave him pills. In the meantime, he goes back to his regular psychiatrist. after we got the records. If you're reading the records of his normal psychiatrist, in August, the psychiatrist wrote twice that Matthew was at a very extremely high risk for suicide or other bad outcome. Now, I'm a layperson. I would have assumed that if a psychiatrist saw that, something would be done. Nothing was done. See you again in 2 weeks, Matthew. 2 weeks later, the doctor writes in the same notes, Matthew's still at an extremely high rate of suicide or other bad outcome. Now, at this point in time, my son and I weren't getting along too well. I was pushing him pretty hard to do things. So I can only assume that I might be, or my wife might be, the other bad outcome. We go along until October 6th. Excuse me. October 6th was the day I was home for a little while. And I decided, I'm just going to go check in his room, go see how he's doing. He wasn't very productive. He was peaceful. He had actually been sleeping in my bed with me, run Debbie out of the bed, me and the dog for 3 months. At the time, I thought, gee, we're bonding. We're doing better. He likes me. I now realize it wasn't that. He was terrified. He was scared to death that the FBI, the CIA, and everybody were coming to get him, and that dog and I would protect him. So I go up into his room. Everything looks normal. Everything looks fine. He's passing his drug test. Everything's great. I find propane tanks like you'd have at your house on a barbecue pit. I find gasoline cans. I find flares. I find rat poison. I found lighter torches, nails, hammers. I'm terrified again, guys. I'm terrified. So I call the local police. Local police comes out. They come up, see everything. And I got to tell you, the police department worked with me real well over the years. They're nice, compassionate, nice, wonderful people. But they told me, it's not against the law to have that in your house. You call us if you have any trouble. So they left. So when my son came back from walking the dog, I confronted my son. Trouble ensued. They took him to the hospital. They were actually going to let him go. They said there was no reason to keep him. He was in the hospital for about 7 days. He was still hallucinating. I told the doctors he was still hallucinating. I brought him 5 affidavits from myself, from workers that were working for me. I brought him another letter from a psychiatrist friend of mine that said if you let Matthew out, he'll kill himself. I brought him pictures of the pipe bombs. I brought him pictures of the flares. I brought him 6 or 7 documents that I thought would prove that my son was going to kill himself when he went let out. Last day before discharge, they said, your son's good to go. He's fine. And they explained to me, and it's in the medical notes, they explained to me the role of a psychiatric hospital setting. And basically, in my opinion, their interpretation, my interpretation of them, it's to stabilize and release the patient. They had checked with the insurance company, kept him 6 or 7 days, let him go. I can't tell you the words I used, but BS was some of it. I was enraged that they would let him out. Told him he was going to kill himself. They told me they had formed a delegate bond and he was going to take his medicine. I told him he had never taken his medicine for his other doctor, who happened to be in the same building, on the same floor, and by the way, they never talked during this whole time. So he's in a psychiatric about to kill himself. They never consulted with his primary physician. Matthew came home a week later, made breakfast, asked me if I wanted some eggs. Told him no. He walked by me. I gave him a hug, told him I loved him. Said he was going upstairs to get ready because he was going to outpatient. He went upstairs. He opened the propane tanks. He had made a improvised bomb out of a shotgun shell. 1 shotgun shell. Gasoline tanks like you'd have around your house, and propane. He locked the door. We couldn't get in, at which time he made a fuse out of sparklers that I'm sure most of our kids have. And he made that bomb and killed himself. Now, one point I'd like to add is I talked to the FBI about this, and 1 tank of propane is equal to about 33 pounds of dynamite. They said it would have killed us all, leveled the house, leveled the neighbors. I just tell you that to give you a story about what I've been through. And one last comment I'll make for this group is good people will die today. More people will die today. Good families will be destroyed. Because we're not doing anything about this now. We are now, but we haven't done it yesterday. And I look forward to the committee, and Mr. Chairman, appreciate everybody being here and tell you my story.
Thank you. We're now going to turn towards Liza Long, who is joining us through video teleconference from Idaho. Thank you for being with us today, and I'll let you go ahead and talk to you about your story. Thank you.
Thank you, Chairman Murphy, and thank you so much for giving me the opportunity to address you about what it's like to be the parent of a child with a mental illness. On December 14th, 2012, 2 days after I placed my 13-year-old son in an acute mental health hospital, the world changed. The night of the Sandy Hook shootings, I wrote a blog post entitled "Thinking the Unthinkable," which included the shocking statement, "I am Adam Lanza's mother." I am not Adam Lanza's mother. I am Michael's mother. I love my son, but he and I and other parents and children like us need help. Like many children with mental disorders, my son has been diagnosed with several conditions. Michael has taken a cornucopia of pharmaceuticals to try to control his unpredictable rages. We have not yet found a combination of treatments and medications to manage his condition. When I asked Michael what he wanted me to tell you, he said, "Tell them I'm not a bad kid. Tell them I want to be well." Michael is not a bad kid. Neither are the millions of other children who have diagnosed mental disorders in this country, and yet we continue to manage mental illness through the criminal justice system. Too often, the only way loving parents can get access to much needed services is by having their children charged with a crime. My son Michael entered the juvenile justice system just 1 month after his 11th birthday. While on probation, he received an array of social services, including therapy and psychosocial rehabilitation, which taught him coping strategies. But once he completed his probation, those services went away. Before my blog went viral, I thought I was the only mother in America who was living in this kind of fear. But I've learned I'm far from alone. Parents like me live in all kinds of fear. We live in fear of stigma. Will my child be bullied for being different? Will my child be the bully? Will I be blamed for my child's explosive behavior? We live in fear of that unpredictable behavior. How will I know if my child's going to explode? How do I keep my other children and myself safe? What about his school and the community? And we live in fear of the future. What will happen when my son turns 18? Will my son harm himself or others? How will I pay for all the services I need to keep my child functioning? And I too have a wonderful employer and private insurance. Parents like me are struggling physically, emotionally, and financially, and mental illness is still so hard to talk about because the stigma for parents and children is real. But as long as parents continue to suffer in silence, the magnitude of this problem will only be recognized after tragedies like Newtown. I wrote in my blog that it's time to talk about mental illness, and it's time to act. What do parents like me need from you? We need access to community-based resources. We need early and consistent behavioral intervention. We need increased funding for the Individuals with Disabilities Education Act, as well as funding for school counselors and behavioral interventionists. We need increased research funding for effective treatments. And most of all, we need a national commitment to end the stigma that surrounds mental illness. As long as we keep treating mentally ill children and adults in prisons, it will be difficult, if not impossible, for us to achieve true parity between physical and mental health. Mental health is truly a bipartisan issue, a problem that keeps millions of American children and their families from enjoying life, liberty, and the pursuit of happiness. As a nation, we must explore creative and brave ways to provide a better life for children, families, and communities. Thank you.
Thank you, Liza. I appreciate that. Well, we've all heard these very moving stories from these parents, and I'd like to start this dialogue going in some other issues to talk about this. We have a lot of reflection on where we go with this. Let me start off by asking Dr. Kopowitz. You have referred to many disorders as something of an epidemic in America. People think epidemic like some other communicable disease. But could you talk about this? I mean, clearly these parents are not alone. There's many more. Could you comment briefly on some of those things?
I think America really does treat the illnesses above the neck differently than they do the other illnesses below the neck. So we have 15 million children and teenagers, people under the age of 24, who have a psychiatric disorder or a serious learning disorder in the United States today, and less than half get any help. That's unacceptable. And the ones that do get help, it's questionable how effective the help is. There's several big problems that have to be addressed, and one Liza just talked about is stigma. The fact of the matter is this country has tackled things like cancer, AIDS. Lance Armstrong made testicular cancer something we talk about. Susan Komen's movement has made it possible for us to talk about breast cancer. And yet people are so ashamed, feeling that it's either their fault or their child's fault or somebody's fault, not the fact that these kids have a no-fault brain illness that prevents them from doing what they're supposed to do. And until this nation really speaks up for kids, it literally takes a month of May and says, this is real, it's common, it's treatable, in the same way that FDR tackled polio or the way that Bush and Clinton tackled AIDS, there's no way that these problems will resolve, because when you're afraid, you're not going to go get the help. The fact that the ranking member tells us that it takes 2 years from the time you get a symptom to the time you get help. And I think the last time I was here, we were talking about something as simple as a rash. If any person in this room got a rash on their right arm today, it would be 2 or 3 hours before we'd put some cortisone on it. And if we couldn't wear our shirt 2 days later because of the rash, 2 days later we'd see our internist. And if 2 weeks later we were still scratching and it was still bothering us, we would be at a dermatologist's office. And yet it takes 2 years to get that help. And the other problem that we have is the access to care. So we don't treat mental illness, certainly we don't treat it as equal to physical illness with our insurance policies. And the system isn't flexible. So one of the things that Pete has talked about, and Pat, which is really disconcerting, is that if anyone in this room started to have chest pain right now and complain about chest pain and maybe radiating down their left arm, and we called for an emergency, immediately EMS would come here. On the other hand, if any of us started acting like we were psychiatrically disturbed and jumped on the table and started yelling and cursing, we'd call the police. And there's something very wrong with that system. The EMS doesn't come, it isn't trained to take care of the diseases above the neck. And so right away we have parents who are forced to lie or forced to get their children into the largest healthcare system, mental health care system, which is the juvenile justice system. The second big issue, I think, is that besides for the stigma, is that there aren't enough people doing this work. You have 7,500 child psychiatrists in the United States. You have 15 million children who have these disorders. The math doesn't work. The only way that's going to work is that pediatricians and primary care physicians, who are the primary people who take care of these kids, have to be better trained. There's never been a better time to do that. You have the Affordable Health Care Act now. You have the ability to say to people, unless you're certified, unless you have some kind of education, whether it's online, in these kinds of disorders as a pediatrician, you won't get reimbursed at this rate, you'll get reimbursed at a lower rate. Or if you have the certification, you get reimbursed for more, for a higher rate. In addition to that, we're never going to produce enough child psychiatrists. So we have to be sensible about this. We have to find social workers or bachelor-level individuals who want to be trained in evidence-based treatments, who work under the supervision of a psychologist or a psychiatrist. We can be innovative with that. And the last piece is we're not doing enough research. We clearly have not, big pharma has stopped investigating new drugs for the central nervous system. And frankly, the National Institutes of Mental Health need more funds to really look at child mental illness or pediatric neuroscience. The fact that 75% of all serious psychiatric illness occurs before the age of 24 and 50% before the age of 14 means that the biggest bang for the buck, the biggest return on your investment is to try to identify these kids early and treat these diseases effectively, but as soon as they show their face, not after years of symptoms.
Thank you, Doctor. And I should let the members know, I'm going to ask another question, but if you want to be recognized, ask a question for clarifying or things. I'll just keep those in order, then we'll go to those. But let me ask Dr. Insole, starting off first with this theme of is mental illness treatable? And more so or less so than other serious mental disorders. You heard these parents talk about they were told, call the police. You heard Dr. Koppel said, call the police. They're not trained in handling these things. If we look at the overall, first of all, effectiveness of treatment, are jails the right place to do this? And what is the cost of doing things through the criminal justice system as opposed to the healthcare system? Can you give us some insight into that?
I'll try. Thank you, first of all, Mr. Chairman and Ranking Member DeGette, for doing this. I think this is, in the 10 years I've been meeting with members of Congress, I think the first time we've had this kind of a forum to have this conversation, and it's extremely important and long overdue. The specific question about what do we lose by moving this into the criminal justice system is the most obvious answer is what you've heard already from the parents who are here, that you're talking about people who are not getting optimal treatment. There are treatments. They may not be as good as we'd like, but they are treatments that help. I should say, just as in cancer and heart disease, they don't help everybody as well as we need, and we do need a new generation of interventions. Some of them, as Dr. Koplowitz has just said, could be medication. Some of them will be more in the psychosocial realm. But what we have is good. It's not good enough. And a very important need here is to figure out how to get the next generation of medicines together. What we lose, of course, in terms of outcomes is, as you mentioned in your question, partly financial. It's obviously much more expensive to be able to try to do this through the criminal justice system, but it's most expensive because it doesn't work very well. What you end up with is a series of recidivist visits, and Pete Earley probably knows more about this than anyone around the table because he's lived this. It's just not the way to manage any serious medical problem. The criminal justice system, by the way, would be the first group of people to tell you that. This is not what they're looking for. But we do not have, at this point, a system that's there to be able to address the need. And so this has been what we're all currently forced into. There are not the community resources, there are not the hospital beds, there are not the crisis centers, and so we're often forced to respond in an acute way for what is often a chronic disorder.
Would you say that's even more severe for the severely mentally ill? It's even
right.
less
So, I think we need to be a little clear about the definitions of what we're talking about. And a lot of what you'll hear about today is a group of people who have what we call severe mental illness. It's about 5% of our population, maybe slightly less, maybe 4%. But these are people who are truly disabled, and very much like the young people you just heard about, they have a psychotic illness, so hallucinations, delusions, and could be mostly a danger to themselves, potentially a danger to others. Definitely in need of treatment, of very aggressive treatment, to be able to help them get through this psychotic episode. For many of them, this becomes a chronic illness with large out-year costs, just like you'd see with diabetes and hypertension. The difference here, and you've heard this in each of the stories we've heard about today, and what makes these disorders so vexing and quite different than diabetes or hypertension is that at the very core, for many, many people with these illnesses, there's a loss of insight. They do not realize that they are ill, or if they do, at the moment when they're psychotic, they reject the notion that they need help. And you heard that in each of these stories, and that's what makes this so difficult to contend with. And that's why these become not just individual disorders, they become family problems. That's why they become problems that involve the criminal justice system, and that's why it has been so difficult to get our arms around this. These are not issues that you talk about when you worry about diabetes, hypertension, other forms of heart disease, issues in which people can bring themselves for treatment and be their own best advocates. Here you're talking about parents trying to advocate for their children, and their children not being able to advocate for themselves.
It's almost as though the disease is on the wrong side. Usually if you have cancer, the patient and the doctor are on one side fighting off the disease. Here the patient is very often with the disease saying, I'm not sick, you're wrong, and the doctor and the family are on one side. The patient is embracing, it seems, the disease because the disease affects their judgment and affects their ability to accept help.
Ms. DeGette.
Thank you, Mr. Chairman. This is wonderful. Thank you for doing this, and thanks to all of our witnesses for coming. It's powerful. And I've worked on mental health issues for many, many years, and all of the things everybody said are things we know, and I think we need to work hard to address. I want to hone down a little bit on some of these issues around some of the violent offenders that we've seen lately, people who have mental illness. One thing I heard from Mr. Earley and Mr. Milam, and I also have heard from people in my district. We learned a couple weeks ago when we had a briefing that some of these mental illnesses, bipolar illnesses that can lead to violence, mostly suicide, mostly against oneself, but sometimes, very rarely, to violence against others. Ironically, it starts to manifest itself among men in the late teens and early 20s, and then among women in the mid-20s. And that's right about the same time when they turn 18, and so the parents don't have legal authority. We've been hearing this from some of our witnesses today. So you have a kid who's 19 or 20 who suddenly starts saying, things that the CIA controlling me and things. And when the parents try to get help, they're told, you don't have any legal ability to do anything. You can't get some kind of a hold on them in a mental health facility and all of this. So my first question, I'm going to ask both of my questions and then the experts can answer it. Are there legal barriers, mainly in state law or federal law, to helping these young people who are exhibiting mental illness get the kind of help they need? Because as Dr. Kopelwitz said, they're on the side of the illness. They're not on the side of their parents or the doctors. And my second question is, what kinds of things, and it's related, what can we do as we start to look at our healthcare policy at a national basis to start to really focus on some of these violent young offenders who are exhibiting mental illness?
Let me ask Dr. Wellner and then Mr. Fitzpatrick to respond to that.
First of all, I want to thank you for inviting me to participate in such a really meaningful program. And I want to acknowledge the importance of the stories that we heard today, which, hearing them for the first time, and as a psychiatrist, as a clinician, and I'm a forensic psychiatrist, so I have a slightly different orientation than some of the others here, you have to hear every story as if it relates in no way to anything you've heard before. And I found in listening to the three parents' stories that the common element was a law that could easily be changed. The three of you have actually come up with something that could very easily be remedied at the legislative level. Now, what am I talking about? First of all, commitment law. Now, commitment law is such that you have parents and loved ones who are forced to lie in order to get treatment. Now, we've just heard about the difference between the medical model and the mental health model. I'll tell you another huge difference. In the medical model, if a parent is concerned and they say, my kid's sick, nobody says, well, let's see if the doctor says they're sick. No. The parent says, I'm caring for this child. I'm the person who may one day, God forbid, bury this child, and I think my child is dangerous, and I'm frightened. And the law says that's not good enough, that a mental health professional, even of the best training, has the power to define, rather than the parent who can give stories like what we heard, which are more detailed than any clinical history that we will ever get in an emergency room or a consultation setting. You could change that law in a minute to allow for the caregivers to have the say in who defines dangerousness. And that's right from this panel today. Secondly, how can we as mental health professionals, best of meaning, and this gets back not only to psychiatric illness, but Newtown. I can tell you as a forensic psychiatrist, I wouldn't generalize across mental illness, but I would say that the most relevant symptom to Newtown is paranoia. So let's say you're interviewing a paranoid patient. What kind of history are you going to get? So the family is essential as an informant. But the HIPAA law says you can't talk. So let me get this straight. You as a family member are going to take the patient back, but you can't have access to the doctor whose well-meaning efforts to provide care have to be handed off to you and could be a patient that's barely wrapped together with no owner's manual for mental illness and no interim manual for managing something you have no professional training. Have a nice life and good luck. You, as legislators, could change that overnight. Overnight. Why is it that parents are not empowered to impact decisions about dangerousness? Why is it that parents, or maybe not parents, maybe just financial caregivers or custodians, if it's a developmentally disabled population, why is it that there is not a natural open line of communication where people can get clinical history passed off to them? So these are solutions that could immediately be enacted. Now, I want to give others a chance to speak, so I only want to add one thing. Those of you who have access to this proceeding and who may watch it one day and who may yourselves have struggled with mental illness, never forget the pain of the malams, because you may feel suicidal, but somebody loves you. And when you go, you will ruin them forever. Think about that while you're here. Think about the pain and the break in so many people who will love you forever when you're here and gone, and don't do it. Thank you.
Thank you, Doctor. Mr. Fitzpatrick, could you comment on that?
Thank you. Thank you for the opportunity to be here today. Clearly what you've heard today is we need a better, tighter, and more diligent mental health system. There's no single coordinated system in this country today. NAMI did a Grading the States report in 2009, and what we found was tremendous variability from county to county as you moved across the country in terms of what services are available. Certainly, as has been said eloquently, the HIPAA laws are legal barriers that really prevent families from having access to the information they need. Families and caregivers are on the front line. They see things first. And so if part of our intent here today is to have the ability to have families access the system, you need to take a close look at the HIPAA laws, and as well the FERPA laws that relate to educational records and health records generated by university centers. Many families and individuals experience serious mental illness for the first time when their family members are 17, 18, 19, and 20. Many of them are on college campuses. Current law blocks families from having access to the conversations their family member may be having with the university health system. And so we need to take a close look at that. The issues around the commitment laws in this country, the idea, and it's certainly been something that's happened to my family, at NAMI every day in our national office and our local affiliates, we literally, over the course of a year, get thousands of these calls from family members who find their loved ones in the criminal justice system being blocked for admission into inpatient units. The reality is today we have fewer inpatient units than we had 4 years ago. And what we need to do is extend those commitment standards beyond imminent dangerousness, as you've heard today, to self and others, to grave disability or need for treatment. We need to simplify the process to allow people to get into the hospital, get diagnosed, and get the treatment they need. So again, the HIPAA laws, the FERPA laws, and taking a look at the commitment laws is absolutely essential, along as has been said a couple times, the workforce issues. In 55% of the counties in this country, there's no practicing psychologist, social worker, or psychiatrist. So the issues around how do you get care once you get out of the hospital, who do you get referred to, and do you get referred to services that are the right services? Are we funding the most effective evidence-based services that really make a difference? And so you need to look at, I always say there's only $1 in this country that funds services to persons with mental illness, and we need to make darn sure that we expend that dollar in a way that really gets the job done.
Yeah, I just wanted to add that I'm much more of an optimist. In my professional lifetime, I have witnessed the treatment, mandated treatment, I might add, of sex offenders go from 0 to 60 in a matter of years. That people who are deemed to be danger to the public because of their criminal deviance, they're very quickly ushered off the street. I've also witnessed in all of the lifetimes of the people in this room the construction of the Department of Homeland Security, again, virtually from scratch. And I absolutely believe that if we created a growth industry, not only of child psychiatry, but also of treatment for the significantly mentally ill who don't just need to be committed, but who need to be kept in a facility where ongoing work can be done so that it is not a revolving door for them because of the public risk, absolutely it can be done. I don't think we have any reason to be futile, and that's why we're all here.
Just one quick follow-up. The other thing that I didn't say that we need to really pay attention to is that whole age group that's in transition, that people really become an adult, and there aren't services like a supported employment, supported education, and case management exists. And so what happens is the families, what you have is an 18, 19, and 20-year-old who's living at home. Their peers have gone on to school, the military, gone on with their lives. They're not in school anymore. They aren't working. They aren't connected with the treatment system. The last piece is, for most families in this country, we didn't grow up with a psychiatrist. We grew up with a general practitioner or clergy. Most people in this country, when they experience mental illness in their family, talk to their clergy first, and then second, perhaps a general practitioner. It takes them a long time to get into the mental health system.
Yeah, we're going to go to Mr. Earley and then Mr. Scalise and then Mrs. Jakowski.
Thank you very much. I'm a great believer in learning from previous events. In Virginia, we had the horrible Virginia Tech shooting. I'm glad to see the congressman from Virginia here. I was on a panel appointed by the governor to rewrite our commitment laws, and we changed it. We changed it to substantial likelihood of danger. And we thought, wow, this is really going to make a difference. The legislator passed $42 million in new appropriations. We went, wow, this is going to make a difference. The next year, the legislator cut $50 million. And today, an IG report came out a month ago that 70 persons who meet the old standard of dangerous to self and others are streeted in the Hampton Roads area because there are no beds. There are no beds. I was just in Dubuque, Iowa. I see Mr. Bradley here. They were telling me they had people with mental illness in emergency rooms 24, 48, 36 hours because there's nowhere to go. My own son had to wait 4 hours to find a bed. This is part, you have to understand, Dr. Wellner hit it right on the head. We need to change the commitment process, but you just can't change that if you don't back it up with services because there's no place to go. Thank you.
Sure thing. I have some more here so far. I'll put you down to Mr. Griffith. I have Mr. Scalise, Mr. Jakowski, Dr.
Mr. Chairman, if I could just make a quick comment on that follows up on what Mr. Earley was saying. And what makes it worse in the Commonwealth of Virginia is we actually have a hospital that's dedicated to mental health in many ways that has empty floors because they don't have the money to open up the floors.
Thank you. Mr. Scalise.
Thank you, Mr. Chairman. I appreciate you having this hearing and especially appreciate all our panelists who are participating and specifically Mr. Milam, Mr. Earley, and Ms. Long for sharing your family stories. And, Mr. Milam, you and I talked about this a little bit, but, appreciate you and your wife Debbie being here and condolences again for your son Matthew. And the experience you went through, and you talked a little bit about in your testimony about the kind of, I don't know if it's a disconnect, but the fact that the treatment center didn't talk to your primary care physician And it seems like with mental illness and physical illness, there's kind of a different approach in how it's done. And, I saw this with my mom who battled cancer for 12 years. And, and over the course of that period, you saw a difference, kind of an evolution in how doctors treated the physical illness and engaging the family more and working to kind of help cure not just the medical treatment that advanced, but also having the family interact and help with that process of healing. Do you see a similar approach on the mental illness side, or some problems, barriers that keep you as the parent when your son would come home multiple times and it was just, did they talk to you about what you're seeing in your son, and when they would send him home, did they say, you really should work on these things, or was it kind of, okay, here, we're done, and he's back to you again?
No, Congressman Scalise, quite honestly, in my opinion, the doctors don't want to talk to you. And I've been told by other doctors, there's no box to check to bill for that insurance visit, quite honestly. And to clarify one point, when my son was put in the psychiatric facility as an inpatient, his primary psychiatric doctor was at the same facility, who he had seen for 6 or 7 years, and never talked. I still don't. I'd like to get the answer to that one day. I don't know how you could find out the most information you need about a patient that's suicidal or that has weapons of mass destruction in his house without talking to his primary care physician, primary care psychiatrist, and finding out the background. He would have also found out that Matthew was not going to take his medicine. Matthew was prescribed Saffras, but as many 50%, I'm told, of bipolar schizophrenics don't take their medicine. So he could have learned a lot from that. And I'll bring out one other point. When they finally let Matthew out against our wishes, and Matthew agreed to go to a outpatient, and I'm told from other kids and stuff, they'll agree to anything to get out. I mean, they're smart enough to learn after 6 days, hey, I'm saved, let me out. But also the releasing psychiatrist from the psychiatric hospital never contacted the outpatient service. And I asked why, and I was told off the record, it's a function of money. We don't get paid to contact those guys. So the other thing to me, and you bring this up, HIPAA is a major problem. I have contacted many people about questions on HIPAA, and I'll give you a few of my questions. One is my son signed a medical release, okay, so that the doctors could talk to us. We didn't know this at that point because the doctors weren't talking to us. We found out after he was deceased, we read the medical records, that he had signed a release. The doctor still wouldn't talk to us. And the ways the laws are written that I read, it's still up to the doctor whether he chooses to talk to you or not, just because a release is signed. The other question I've asked is, and no one can seem to quite answer this for me, if a patient signs a release and then he cancels that release and then he reinstates that release and then he cancels that lease, does there have to be a paper trail on that? Because I can't seem to find one. Doesn't seem to be a rule how that works. So how do we know whether doctors can talk to a patient? Because if they sign a release and then they verbally cancel it, who would know? And none of that's documented in the medical records either.
I'm going to ask Dr. Torrey to come into this too, but I also wanted to let some members know something interesting on this. 4 states and the District of Columbia have claimed that the HIPAA, that is the Health Insurance and Portability Act, privacy rule is preventing them from putting records into the National Criminal Database. Rhode Island so far has submitted 0. Montana, 3. Mississippi, 3. Washington, D.C., 477. New Mexico, 5,000. I think maybe Maryland, 64. By comparison, I think Virginia is like 180,000. And they're saying this. Now, the committee did send a letter over to Secretary Sebelius asking her to clarify that when you have someone who is violently mentally ill or has been through a commitment law, they would not be able to purchase guns. A lot of times those records, the states have not released them claiming HIPAA law problems. I think it's a judicial issue, and quite frankly, I think they can release it, but just so I'd point that out as a fact.
Mr. Chairman, let me just say, as someone who was here when we wrote HIPAA, I don't think HIPAA prevents those records from being divulged at all. And I think people are misinterpreting HIPAA, and I think that's one thing we need to talk about in this committee.
Well, let's find out. Dr. Torrey, make sure your mic's on and you're pointed to.
Thank you, Mr. Chairman, also Mr. Geet for inviting us, and also for this very important look at severe mental illness as a factor in the tragedies that we're looking at. We've heard a lot about gun control. Guns are certainly a major part of the problem. Untreated severe mental illness is certainly at least as big and probably a bigger part of the problem. And I want to go back and just focus on the single biggest impediment that we're talked about is the fact that people with severe mental illnesses are different from people with severe physical illnesses in one important aspect, in that about half of them have an impairment of their understanding of the fact that they are sick. And the reason they have that is because they have damage to the parts of the brain that we use to think about ourselves. In this sense, someone with schizophrenia or bipolar disorder or severe depression with psychotic features is not exactly like someone with cancer. And the laws don't really reflect this on it. About half the people with schizophrenia have impaired awareness of their illness. And we're not talking about denial. We're all very good at denial. But we're talking about a part of the brain that is affected, the part we use to think about ourselves. We see this in Alzheimer's disease also, that impairs your ability to understand that you are sick and that you need treatment. We heard this from Peter Earley and Mr. Millam and Ms. Long. Certainly occurred in all three of those. We now have studies that show that the brains of people with schizophrenia and some with bipolar disorder, when you look at them, there are changes in the brains of the people who have these impairments compared to those who don't have the impairments. Last year I reviewed 18 studies along these lines. 15 of the 18 studies showed significant differences in particular parts of the brain that we use to think about ourselves. There's 2 other studies I know have come out in the last year. So really 17 out of 20 studies that have looked at this show that the brain is different, and yet the laws do not reflect that. Unless we have treatments that reflect the fact that we are dealing with people who don't understand that they are sick, then the treatments will not be effective on it. Example, my sister, who had schizophrenia for 53 years before she died 2 years ago, never understood that she had schizophrenia. I would say, do you think you have schizophrenia? And she'd smile and she'd say, well, I know you think I have schizophrenia. I'd say, no, well, why did they keep you in the hospital for 25 years continuously in upstate New York? Say, well, you know, I don't know. I had a cold when I went in the hospital. I don't know why they kept me all that time. This is a problem that unless you actually deal with it in the laws and in the treatments, we're not going to go anywhere. Thank you.
Thank you. Okay, I have Schakowsky, Burgess, Braley, Cassidy, Tonko. So, Ms. Schakowsky from Illinois.
I want to make 3 points and then get some reaction. We have been talking about potential solutions, so Mr. Chairman, Ranking Member, just want to say that there are a couple of bills I have, but I don't want to go into them, but I just want to. One has to do with Mental Health on Campus Improvement Act. It's 15 years this month that one of my best friend's son, at 20 years old, committed suicide on the Harvard campus. Popular, doing well in school, no one could figure it out, clearly, obviously, mentally ill. And she had asked me at that time, isn't there something that we can do to provide more help to college campuses to identify and to treat the problem? So I wanted to just get some reaction to that. The other, Dr. Koplowitz, you talked about expanding the availability of mental health professionals. I have legislation that would allow clinical psychologists not to have to be, not to expand their scope of practice, but not to have to be under supervision of a physician to offer that service. What you thought about that? And finally, I wanted to say something to Dr. Wellner. I was looking at the end of mass murder, the document superposed, and it says what you can do as parents. And it says, first, teach your children to take personal responsibility. A child who is instilled with taking ownership and responsibility is not inclined to blame others, and so will never come close to the patterns of blame that generalize to those he has never met. It feels to me, with that kind of statement, that somehow it adds to the feeling of blame and responsibility without recognizing and stigma, without recognizing that we're talking about mental illness, not just how we as parents teach our children that, you know, sometimes these things especially with these huge mass murder situations, go beyond that. And this doesn't feel good to me. It seems to add to the stigma idea.
Dr. Capo, do you want to answer the first part of that question with regard
So
to
I think there's an important piece here. Let's remember that the suicide rate in this country for people between the ages of 14 and 24 is going to be 5,000 people will lose their lives this year. 600,000 will make a serious enough attempt that they will go to an emergency room to get treated for that attempt. And the reason for that is we know that there are brain changes that occur in individuals when they're 13 and 14. The brain is basically very bushy and it starts pruning itself so it becomes more efficient. And for people who have very serious psychiatric illness, it over-prunes. And there's a reason why Hertz and other rental companies don't let you rent a car until you're 25. And it's not because they have neuroscientists working at Hertz. It's because they have figured out that the accidents that people have between 18 and 24 are so much more significant that if they wait, the brain looks better and we calm down and suicide rates drop. So it's particularly important that college mental health be an important component of this. And it's not that Harvard causes this or the University of Maryland where I went. It is the stress, obviously, of being separated from your parents, but it's the genetic disease that is coming out that, it shows its appearance at this very crucial age. The real problem, I think, is the fact that we don't let colleges share information with parents so that when a kid starts showing symptoms, the important piece is that you could reach out to a family and say, your son is in trouble or your daughter's in trouble. And when you think back to Virginia Tech, it's also the attitude the professors have. So that if someone sat in the room and was bleeding from their nose continuously, someone would say, there's something wrong here. You have a clotting problem. You can't come back to class. You might contaminate someone. Or if you were coughing, you would have to be checked for TB because you might contaminate people. And yet, at Virginia Tech, there was this menacing individual that was so scary that people sat by the door afraid that maybe they'd be able to run out. So quite clearly, that has to be corrected, that colleges can share that information with parents. Can you imagine if your kid's on scholarship and the first notification you get is he's lost his scholarship because he's stopped going to class because he's mentally ill and he's doing bizarre things? That's the first time you get called. The second issue you talk about is the idea of more, of letting psychologists, I think are you talking about prescribing a medication or just not being under the supervision of a psychiatrist? In most states in the United States, licensed psychologists are really quite independent. And in fact, I think the more important part that we should think about is there is something we can do if we think about the schools of psychology and the schools of social work, that only 20% of them, studies have shown, are educating people on evidence-based treatments. So that you go and get your social work degree or you get your doctorate in psychology and you learn about supportive psychotherapy or you might learn about analytic theory, but you're not learning about the most cutting-edge cognitive behavioral therapy, interpersonal therapy, the stuff that we know has some evidence, psychosocial interventions that can really make a difference. And there is no certification program. There is no licensing that says this is what's required. The way in medical school, there are certain things you must teach people to get their medical degree.
I want to keep this moving so we can get a lot of members' questions in too, but Doctor, if you could comment on what Ms. Shikowski said, but really hone it in also about how do we identify those who are particularly at risk then for some of this and to prevent them from taking that next step of violence?
Congressman Shikowski, I appreciate your question. I think actually what you've raised is that we haven't heard anything about the Newtown type of individual here today. And you've actually asked the question that introduced it. And the point from my experience and what we've learned from the literature is that a great number of people who carry out mass killings don't have a psychiatric illness. They have a personality disorder. But what is common to all is that they have a brewing resentment and blame and an externalizing responsibility to others. Now, if you tack on a paranoid condition and a full-blown psychotic paranoid condition to that, well, then you have an individual who's already been loaded by how he relates to the world, who then has a psychotic condition on top of that. But for those who are along a path of increasing isolation because they get into a way of relating to others that it's always their fault, that what parents can do at an early age, because every parent in America asks, how can I prevent the unthinkable from happening? The idea of how a child relates to the world, one can actually make a difference beyond nature. Some things nature, the last quick point that I would add to what Dr. Koplowicz is saying, in my professional experience in dealing with these cases, the mass killer at risk population is actually much harder to treat and manage than even individuals with psychiatric conditions who have denial or who are struggling in a different stage. This is a unique and difficult population. I am concerned that what we need in the psychiatric and behavioral science fields is better training. We have to incentivize better trained people to deal with the most difficult populations rather than make qualifications available to people who might not otherwise have an opportunity to be nominally in charge. We've got to have mental health SEALs. That's the population of treaters that need to be redirected and focused to these high-risk individuals, because a lot of them are in treatment with people who care, and somehow they crawl into the cracks so that they can act on a homicidal fantasy.
Dr. Burgess.
Thank you, Mr. Chairman, and thank you for holding the hearing. Well, first off, let me just ask a housekeeping question. Since this is not a hearing, are we able to submit, there's a lot of questions a lot of us are going to have. We won't have time to get to everything. Will we be able to submit questions for response?
Sure. I'd be glad, if that's okay with the panelists, I'd be glad to forward those on, yes.
I think that's an important part of, in fact, continuing this dialogue into the future. Mr. Earley, I wonder if I could ask you, and I do thank you for sharing your story with us. I mean, Dr. Wellner prefaced one of his comments with, for people who are watching this at some point in the future, you told us a very compelling story. I think it had a positive ending, but I don't really know how you got there. So since we should be about solutions, can you share with us how you got to the positive ending?
Absolutely. Thank you very much. My son finally got the community meaningful service that he really needed. He got a caseworker. That took a tremendous load off of me. I could be the parent. Can you imagine every conversation I had with him before that? If he'd laugh, I'd go, is he off his meds? If he'd cry, I'd go, is he off his meds? All of a sudden, I could be the parent again. I had to become his partner instead of being the parent who was just telling him, go get fixed. I had to learn to teamwork with him. But he got him here. It's not rocket science. What do people with mental illness want? They want a purpose in life, they want someone to love, and they want to be somewhere where it's safe. The worker said, look, we're going to get you into housing because living with your father apparently at your age isn't the really smart thing. So they got into housing with two people with schizophrenia, and then she said to him, why don't you take your meds? Do you know my son's had 7 psychiatrists, only 2 have bothered to learn anything but his name and his symptoms because psychiatrists are paid for 15 minutes, figure out what the med is, stick a pill in, and let the social worker, who's cheaper, do the work. Treating the mind requires treating the heart. So they said, well, I didn't like the weight gain. Okay, let's try this. And all of a sudden, he became compliant. Then she said, what do you want to do with your life? Gee, I don't have to just be on disability? My son has never been on disability. I've fought that from day one. And he said, no. And so my son became what's called a peer-to-peer support specialist. He is actually paid by Fairfax County now to go into jails and prisons as part of a jail diversion team and help people with mental illness get out and get their lives together. So he is an amazing success story. He's been stable for 6 years, and it's because people took the time, the effort, and gave him the services they needed to move forward, and now he pays taxes.
So he's become one of those mental health SEALs that Dr. Welder referred to. Is that right?
Most people with mental illnesses can get better. You got to give them hope. You got to give them the tools to do it. Now, the ones with severe mental illnesses are going to require a lot more, but most can get better.
Well, let me just ask you a question. What prevented the intervention of a mental health caseworker at one of his earlier interventions or ER visits?
You know, my son and I fought about this all the time. It's, even if you, Dr. Torrey put it so well, even if you are cognizant enough to realize you have a mental illness, who wants to admit that? Who wants to admit that your brain is impaired? And so he fought that and fought that and fought that until he ended up being arrested 4 times, tasered with the police, and all of a sudden the reality set in. And a doctor told him, every time you're having a significant break, you're killing parts of your brain. And that finally did it. But how each person reaches that is I wish I'd be a rich man if I knew how to do that. But he finally realized it. But when he did, we had the services in place to get him the help he needed. And that's why services are so crucial.
And I don't disagree with that, Mr. Chairman. I do feel obligated to point out, there's a cautionary tale here as well. I mean, I grew up in the 50s and 60s, and I remember the state schools and state hospitals in Texas, and those were criticized, and I think by the federal government, because of warehousing of individuals and providing no meaningful treatment. I have an article here from 1991 New York Times indicating the abuses of a group called Psychiatric Institutes of America that hospitalized adolescents for the 1 month period that their insurance would cover. It was a very lucrative business for that entity. They didn't really help anyone. And I don't know if some of the difficulty that you had, Mr. Earley, was because of the reaction that someone took legislatively to that abuse and that fraud that occurred. I remember those clinics, those facilities in my home state of Texas. They were really quite predominant, quite rampant at that time. Obviously, the Justice Department required them to come up with all kinds of fines, and people got in trouble. And as a consequence, then I practiced OB-GYN. Very, very difficult then to get someone into a treatment facility after that, because nobody wanted anything to do with it. Because look, these people got in trouble and they were doing things wrong. There's no question about that. And Mr. Chairman, I'll submit this 1991 New York Times article for your
appreciate it. We'll make sure the
reminders. Yes, sir. Mr. Earley wanted to respond.
Nobody wants to go back to those old days, and you had to realize that those kind of facilities should have been closed down. Absolutely. In Virginia today, though, if you go through the involuntary commitment process, if you become the enemy, if you make your son go into treatment, the average length of stay is 5 days. Do you know the therapeutic level for my son's drugs is 5 weeks?
Sure, of course it is.
And the other thing I'd urge you to remember is this. Yes, we closed down those horrible facilities. We have moved people back in the community, which is where they belong and where they should be. But if you read my book, you'll see that we're putting people in substandard nursing homes where we have them homeless, and most of all, they're in our jails and prisons. Your state, Perryman report, studied how the economics of this and how much money your state was wasting because of people in jails and prisons who could have gotten help. And I'll pull it off the top of my head, but I think for every $7 it was spending on incarceration, it was costing $7 when community services would have cost $1.
Yeah, so, and I don't disagree with you. We should be about solutions, but we also need to remember some of the pitfalls of the past.
Absolutely.
Thank you, Doctor. I'm going to go to Mr. Braley, Dr. Cassidy. You have a quick comment?
Visiting my district. Mr. Chairman, there's an insurance company called USAA that sells its products to members of the military and their families. And they have a marketing campaign right now where they have ads on TV that show people, they say, mine was earned, and they identify a specific battle or a moment in history when their family started using that product. My understanding of mental health was earned when my dad came home from Iwo Jima after seeing a friend of his vaporized by a shell burst, and when I was in high school, had 2 severe bouts of depression. And I learned a lot about how people respond and don't respond when someone is suffering from a severe mental illness. And one of the things you learn is that in addition to the compassion that family members bring, there's always resentment. Resentment because you can't find solutions to problems that other people don't understand. And I appreciate my colleague's comment about some of the past abuses which have created the current legal system we have that is creating these obstacles. Because it used to be that putting someone in an institution involuntarily could be used for punitive measures by husbands who were upset with their spouses and by families who were tired of dealing with problems they could not solve. We have to remember that right now, these issues are dealt with on a state-by-state basis. So we have 51 different solutions. And that is why this is such a difficult challenge to solve. We know that individual states have legal proceedings, like a guardian ad litem proceeding or a conservatorship that gives parents and concerned family members the opportunity for greater access to involvement in the care of a loved one, but those are cumbersome proceedings. And we don't know how we can expedite that under the circumstances we've heard from these families today to protect the rights of the patients and to get parents more involved. But I can tell you, when I talk to mental health professionals and law enforcement officials in my district, we come back to the same problem we dealt in the aftermath of 9/11, and that's this whole issue of interoperability and how interested organizations that are concerned about solving these problems cannot communicate with each other. And it seems to me that if we're ever going to get to the root cause of how we solve the problems we're talking about today, we have to bring in state officials who are involved in making these decisions on a day-to-day basis and come up with constructive solutions that are going to get people more engaged, more involved, and in a more timely fashion than we have been. But I think it's a much deeper problem than saying we can come up with a solution by clarifying the intent of HIPAA when it's being interpreted by state law officials in all these different jurisdictions. So I just want to thank all of our panelists. It's been very illuminating, and I think you have really put a fine point on why this is such an enormous challenge for us to take on.
Maybe I could ask a couple of the parents to come in this. Maybe Mr. Milan and Eliza Long, if you could comment on that briefly, on what you experience in terms of those barriers and laws.
Well, my personal opinion is the doctors use HIPAA as a weapon. They don't want to talk to you. They don't want to talk to you. You know, I tried one-way communication. I must have sent 300 emails, pictures, texts, everything else, with the final realization that the doctor at about 18 was not going to return Debbie's calls. He was not going to return my calls. You know, I even, the last day of 3 days of Matthew's life, sent a fax to the CEO of the hospital begging him for help, saying, look, I don't need to know anything about my son. It's not about HIPAA. Help me save his life. No response. I'm just told day in and day out that it's HIPAA, HIPAA, HIPAA. We can't talk to you.
Ms. Long, could you comment on that? Is that to follow up with Mr. Burley's comments in terms of confidentiality laws that are being brought up that preventing people from communicating in your son's case? You've seen some of those barriers?
I'm actually very fortunate, but Mr. Milam has explained exactly why I'm concerned about what happens when my son turns 18. Right now, my son's still 13, so HIPAA is not an issue for me, but it's certainly on my mind for all the reasons that Mr. Milam articulated so well.
Thank you. I might add, I know the members might want to check this out in their own states. I know in Pennsylvania, 14 is the age of maturity. I mean, I wouldn't let a 14-year-old do much of anything else. I'm going to go Mr. Cassidy and then Dr. Torrey. Because he's been hanging it there.
Thank you, Mr. Chairman. A couple things. Although there seems to be a consensus here, there's two issues, obviously. One is commitment, and the other is the ability to understand commitment of an adult family member, number one, and number two, the ability to get information about that adult family member. Two different issues. So, Mr. Earley, I'm about to reference you. You may want to, I'm sorry. There seems to be a kind of a consensus here that we have two issues. One, the change in the commitment laws to allow adult family members to be committed, and secondly, the HIPAA laws. And there's almost a consensus here that these need to be addressed, but in your book, Crazy, you do a fantastic job, and Dr. Torrey, you as well have referenced this, that there is not consensus on this, that there are activists out there who would, and maybe there's somebody here who would agree with that, who would absolutely oppose changing current commitment laws, and potentially absolutely oppose changing current HIPAA laws. Now, that said, even though there seems to be a consensus, because of you, I understand there is not, so one, how do we address that? Secondly, for Dr. Torrey, after that is addressed, you have been a really sharp critic of SAMHSA, and you've also proposed federalization or block granting federal dollars to the states. If we're going to federalize funding, don't federalize control. So I'd like you to comment upon that perhaps after Mr. Earley speaks.
Mr. Earley.
No one wants to have their rights taken away from them. And it is a slippery slope that we really have to watch. If you look at the history of where this law came from, you'll see that it came from what Mr. Burgess was talking about, where people were arrested for having a mental illness. They were stuck in an institution, had an ice pick stuck up behind their eyelid, and their front brain scrambled and said, "Congratulations, you're cured." And the civil rights movement switched over, and they said, "No, you shouldn't get arrested because you have a mental illness. You shouldn't get forced to be treatment. You should have a voice." And most of all, they targeted involuntary commitment because they believed that putting someone in one of those institutions was worse than letting them on the street, and they made imminent danger the toughest criteria. We have to have safeguards. I want to protect my son. I know how people with mental illness have been treated in this country. I'm just saying that the imminent danger criteria is a false criteria. Absolutely.
But we actually looked at having Matthew committed conservatorship, what do you call it in Louisiana. My father-in-law, who's an attorney, that actually prepared half the documents. And we realized in the condition he was in, the rage he had, potentially, a time bomb, that it would take us literally 2 months and probably $20,000, which wasn't the problem. But 2 months, he would have had a court hearing, then they would have scheduled for doctors, and he would have had another court hearing, and that just can't work with a person that's potentially violent.
So if you're in the acute problem, the process of adjudication defeats your ability to have the acute problem addressed.
I thought my son would take his life the minute we told him, by the way, we applied to have you committed today.
But it turns you into the enemy because you then, as the parent, take him before a judge, and if that judge or that psychiatrist says, "Gee, he's not a danger to himself," at this very minute, they say, "We're not going to commit him," who takes him home? And believe me, they are not happy. So I think the dangerous criteria is a false criteria. I think what Mike said earlier about trying to change the wording to make it easier to get people who are seriously ill into the treatment center, and then you build in more safeguards that if there are parents who are just trying to dump their kids, or if there are people who don't need that kind of help, then you can get them out. Maybe you have a 3 psychiatrist panel, or you have some way to do it. It's just now we have the barrier here, when I think we should have it after you get someone who may need help into treatment here.
Louisiana has something like that. I'm a physician in Louisiana, and Mr. Milam, clearly you went through the PEC process, and it still wasn't adequate. So I think we're working towards it, but I'm not sure we're there.
Yeah, I was just in Baton Rouge, and again, it's the other side of that. You guys are short on hospital beds. You're short on facilities.
Yes, Dr. Torrey to respond to that too.
Yeah, thanks very much, Mr. Cassidy. As Mr. Brawley also said, these are state commitment laws, and I think we shouldn't be under any illusion that the federal government or this group or any group in the federal government can magically change all of the state commitment laws. These are state laws, and I think properly so on it. I think what we can do is use the federal money that's already available and out there to provide models so that we understand what proper treatment would be and can be. Yes, you're correct, Mr. Cassidy. I've been a severe critic of SAMHSA. I think they're not doing the job that they should with their $3.1 billion budget, but that includes several $100 million in a block grant that goes out. I would argue that that could be used very well to provide some models on how treatment can use, for example, assisted outpatient treatment, which does account for some people who do not have insight or awareness of their illness, and we do know does decrease hospitalization, decreases violence, and also saves money. This is a proven way to treat people, such as we're describing, especially those who are not aware that they're sick themselves. And this would be a good use of SAMHSA's money on a basis where you're actually following these and measuring the outcome, ascertaining what kind of decrease you have in hospitalization, jailing, et cetera, I think this should be absolutely the way we should be going. But that's not what SAMHSA is doing. The one treatment that SAMHSA proposes, which is called recovery, specifically does not include half of the people who are not aware of their illness. Recovery, by definition, insists that you must make the decision yourself. So the only treatment SAMHSA proposes is a treatment where the person has to agree, which is fine for the half the people who are aware of their illness. But for the half the people who are not aware of their illness, it's completely irrelevant. Thank you.
Yeah, Dr. Fuller.
Yeah, Congressman Cassidy, I just wanted to throw down something because I appreciated your framing what we're talking about. I think there's actually more that we should be throwing down here as long as we're talking about Newtown. Professional experience has taught me that the three most important symptomatic elements of the mass killer are paranoia, hopelessness, and masculine identification with destruction. There's a reason why heterosexual males are the overwhelming majority of people who are carrying out mass killings. And if we completely limit our consideration, just as it is with guns, to the idea of psychiatric illness, then we're recognizing some of the obvious qualities of this. I would also add that while medications are very effective for paranoia, we're also dealing with a population that, beyond those who fall into the cracks, many, and perhaps most, mass killers, because it's not an impulsive decision. It's a decision which one deliberates and then becomes determined. And once they become determined they'll do it, they crawl into the cracks. They keep themselves from being appreciated for the risk that they represent to others. The people that we've heard about today did not have the broad resentment of society to lash out. They killed themselves, they were violent within the family, and research demonstrates that the psychiatric illness dangerousness link is within the home. When a person lashes out at the general community, that's a different individual with different pathology. And this is why, beyond this, we can never, with all good intention, all application and example of federal law, and all well-meaning states that pick it up, we will never resolve the issue of mass killing in the United States in particular with good mental health care until we deal with the cultural forces of entertainment violence and the video game detachment that at the other end are influencing vulnerable people to identify with destruction at a time when they're finding themselves as men.
But are they preventable? Can we prevent, through treatment, through identification treatment, prevent some of these mass killings?
The key thing is, and I think Dr. Torrey brought up a very important point. If you appreciate that mass killers involve such a high concentration of folks who crawl into the cracks, you could build the best facility in the world and have the best staff. They're not going to come. You have to go to them, and you have to engage them at a level and in a dialogue that they're willing to have with you, whether you're informal, whether they don't appreciate you as a psychiatrist and you're as a caseworker. And this is why the assertive community model has such promise for folks who either are in denial because they have a lack of insight or are invested in destruction and have to be defused by those mental health SEALs who are especially capable, just as a hostage negotiator would be.
Dr. Insole, you want to comment on that too?
Yeah, I think the one thing I would add, and it goes back to your question, Dr. Cassidy, is these are treatable in the sense that we know that the risk of violence in someone with serious mental illness goes down 15-fold with treatment. Doesn't solve all the problems, but that part of the problem is entirely treatable. It's getting them into treatment, which is what you're suggesting is where the real struggle is. And let me just clarify, this is not a new conversation. You know, we have been talking about how do you find the right balance between individual rights and public safety for 5 decades. And after big events like this, we went through the same thing with Virginia Tech. We sort of rebalance where we want to be. At the end of the day, it's a state-by-state decision. What I hope we can do is bring better and better science to that question. I think there are real opportunities through CDC, NIH, other research agencies to try to understand what has worked best and what hasn't worked well. But we do need to be very careful about making policy decisions in the wake of a rare event like this, that as we rebalance this, we don't want to go too far in one direction or the other. It's got to be a very careful conversation.
So would you, now are you the counterpoint to Mr. Earley's, again, writes persuasively in his book, that the folks that would say this incompetent adult, not speaking pejoratively, but just technically, this incompetent adult without insights by nature of their illness should not have the right to make a decision saying no to appropriate therapy? I mean, I think Mr. Earley bridles against that from his personal experience totally relate to that. Someone who's mentally incompetent saying, no, I don't want this therapy. Would you say, no, they should have that right?
It's not, I don't think it's going to be a black or white call. I mean, you're going to have, you want to look at the unintended consequences.
I accept that, but at the same time, at some point, public law is a little bit blunt.
Right. It is.
And so either currently, as I understand, and again, there's a Wall Street Journal article about the family of Bruce's, I think, where the man's released kills his mother. And the family was never informed. So it's both a commitment issue because he was coached on how to get out of a commitment and a HIPAA issue. So I guess my question for you, Dr. Insole, is would you say, no, that's the appropriate level of the law, or I don't know where you're coming down. And
yeah, so what I'm saying is I think this is the exact conversation to have. I'm not going to give you a direct answer because I don't think there is a direct answer, but I think in every state, this is a conversation that we're trying to encourage. It's part of why we're.
But if we can't answer it on a federal, if we can't answer as public policy makers, then we got to despair.
But I think this is the conversation, Dr. Cassidy, to certainly have. And as Dr. Torrey said, this does play out in every state. And to your first question, is not all the groups who weigh in on this, as Tom said, are here today. And so there is a robust dialogue that's gone on. My concern, though, is we focus on Virginia Tech and we focus on some of the Newtown tragedy and what have you. Smaller versions of this happen every day in this country. And it happens with people who are untreated, have no insight into their illness, and their families can't get access to the system. So we need to have this dialogue, and Tom's right. After every one of these tragedies, we have these dialogues. But this is an opportunity to, I think, rethink, revision how we do this and how we get people into treatment before they die under a bridge in the winter, before something happens within a family that's tragic.
Castor, Florida. I'm sorry. No, she wanted to bring into the argument, into the discussion too, Ms. Castor.
Well, thank you very much, Mr. Chairman, and I do want to thank you for your outstanding leadership in convening these hearings. And that's a good segue, actually, because I'd like to focus on what is working out there and what you all can highlight that we need to do more of, because we've got to be as efficient and as effective as possible with the scarce resources that we have. But first, I'd like to thank the parents on the panel who have shown great bravery in coming forward and telling their personal stories, because you represent thousands, maybe millions of other family members who have struggled with similar challenges. And I'm curious, before we get to highlighting what is working and what we can do better, when did you notice the mental illness manifesting itself? And was it identified by others, a teacher in a classroom, or someone on the Little League team, or the scout troop? Maybe I'll ask if Ms. Long is still available. I could ask her first. When did you notice it, or was it someone else, like a teacher?
Yeah, it's kind of a complicated process. My son is not my only child. I have 3 other children who do not suffer from mental disorders. I did notice little things, especially in hindsight, behaviors that maybe were a little different with this child compared to my other children. But we definitely knew by kindergarten. We had a clear the room safety order in kindergarten for my son, which just seemed like, okay, yeah, that's what we're going to do. We worked with a variety of psychiatrists, therapists, diagnoses across the board, everything from oppositional defiant disorder, intermittent explosive disorder. Right now we're looking at an autism spectrum and ADHD, possibly bipolar, but we struggled for a long time. Things really became exacerbated when he went into middle school. And he's now actually in a pull-out program with children who suffer from emotional and behavioral issues. So he's not able to be mainstreamed with other children at this time in school. So we definitely noticed early, and then it's progressed.
Okay, thank you. Mr. Millen?
Yes, I'll probably get this wrong. My wife would probably correct me, but it was in the early teens. Matthew was diagnosed as ADD, ADHD, and we started having some problems with that. But it just gradually got worse, and no matter, like I say, he was treated by one of the top psychiatrists in New Orleans for for many years, different medications. But I go back to the main issue with Matthew is if he took the medication, okay, when he was in trouble and he took the medication, he was fine. So there needs to be a mechanism that if patients aren't taking their medication, what does a parent do? You can't make a 21-year-old man who's living in your home take his medication. You can't go to the doctor. He won't talk to you. You know, you just have no mechanism to try to fix the problem when you know the medication helps.
Secretary.
The obvious mechanism is what we call assisted outpatient treatment. Louisiana has it, but uses it very rarely. 44 of the 50 states have it. 6 states do not have it. Basically what it is, and I used this when I was in St. Elizabeth's Hospital for 8 years, the District of Columbia has it, is I would go to the court and say, Your Honor, this individual has been in the hospital 19 times. He has no awareness of his illness. I brought his mother and sister here today to explain what happens when we let him go each time. He never takes his medicine. In fact, we've seen him throw his medicine in the garbage can on the way out of the hospital. The judge then says, we're putting you on assisted outpatient treatment, which means you have to come back every 3 weeks, get your injection, and if you don't, we have the right to bring you back to the hospital. That's what assisted outpatient treatment is. We know that there are 6 studies showing that it decreases hospitalization, studies showing that it decreases homelessness, decreases victimization, decreases arrests, decreases violent behavior. Studies in New York and North Carolina specifically show that this decreases violent behavior by severely mentally ill individuals, and it saves money. A study in California said it saved $1.81 for every dollar invested in AOT. North Carolina found that for people on AOT longer than 6 months, the cost savings were 40%. So we know this works. We know it's not used except in New York State, where it's used fairly widely, but not as widely as it could be as Kendra's law. But otherwise, because of the problems we're talking about, there has been great resistance to using any kind of treatment that involves involuntary medication, which this does, but you're dealing with people who have brain injury that impairs their ability to make those kinds of decisions. So in answer to Mr. Cassidy's question, yes, some of these people need to be treated involuntarily.
Mr. Earley, can I ask you to identify the early stages when you identified?
My son was 22. He was a college student, and all of a sudden he started complaining that food didn't taste good. And I rushed up to see him after several months of this, and he just couldn't eat. So we thought something was wrong. We took him to a psychiatrist. I'll never forget, the psychiatrist said, if you're lucky, your son's using drugs. If you're unlucky, he has a mental illness. Well, of course, then I dismissed the psychiatrist. I mean, who says that kind of silly stuff? He gave my son medication. My son quit taking it after a few weeks, and I was so naive, I thought, well, it's like aspirin. You have a headache, it goes away. And I just didn't think about it. A year later, he was psychotic, like I explained. We looked back, and you have to be careful because it's real easy to look back and go, oh, well, that's why he did that. Or there were no signs.
I know that the chairman wants to move on and then come back to what works well, but I have to say what I'm hearing from families at home and educators and from Dr. Insole and Dr. Kovowitz at our last briefing was the pruning of the brain early, the identification of changes in behavior and activity. We've got to figure out how to give educators and mental health professionals and families the tools as early as possible to identify and then to treat. SAMHSA does very well. In defense of SAMHSA, I think they really put some outstanding tools in the hands of professionals at home. But I'm worried about a disconnect now with the resources that aren't available through schools at home, especially. And then for you all who had health care coverage, you seem to be able to access greater treatment, and there is a large segment now that are uninsured that is going to change. How can we best impact the growing number of insured to make it meaningful for mental health coverage?
I think Ms. Long wants to comment on that. Eliza, do you want to comment on make a comment?
I would, thank you. I wanted to speak to the problem of lack of insurance or coverage for mental health. In my own case, my son racked up possibly the world's most expensive library fine. I asked him to return some overdue library books. He completely went into a rage, threatened to kill me, threatened to kill himself, pulled a knife. I was able to get the police involved. They had to transport him by ambulance to the emergency room. By the time we got to the emergency room, he'd calmed down. It just so happened we did not have insurance that covered mental health at the time. So he was declared stable, and we were sent home with a Zyprexa.
Okay, thank you. Dr. Insole, you want to comment on that too?
Yeah, this is actually in reference to what works, and I would go back to Dr. Torrey's statement about the importance of thinking about options like assisted outpatient treatment. And as he said, the science says that actually works to reduce violence, but I think both of us, and probably the other psychiatrists at the table as well, would say that's a really low bar. I mean, that's really not where we want to end up. Important to do. But the real question is, what do we have in place and what can we deploy to make sure that people finish their education, get jobs, have families, contribute in some important way? And there is now an entire package of interventions that help in that respect. They really do help people to work, and they do help people to get back involved. You heard this from Mr. Earley about some of the things that have made such a difference for his son. The problem is they're not available in many places, and they're not integrated in a kind of package of care that you would expect. We do this pretty well for diabetes now. You know, we know that you need really good diet supervision, you need some kind of an exercise plan, and you need to take your insulin, and there's a whole realm of people who can make that happen. In this sphere, not so much.
I think there's also... Michael, you want to...
I'm going to go to Dr. Wellner.
Yeah, I wanted to make a couple of quick comments. First of all, I think the issue that we're hearing about now is compliance. I think there are two aspects of it. One is just getting someone to comply to go on a medicine, but the other is to get them to stay on. Now, with involuntary treatment, you can get someone to take medicine for a certain amount of time, but sooner or later you're going to have to, as they say, meet Jesus. You know, you're going to have to get to a place where the person, you're going to have to bring somebody to taking that medicine that they don't want to take. What I have found as a clinician, which is much more difficult for younger people than it is for an older dependent, is you must find your leverage within the relationship. For some people, that leverage is, hey, I know you don't believe that you're ill, you don't believe you need these, but if you don't take this medicine, you're going to lose your child because of certain complaints and certain issues that have come up. For others, hey, I know you think it's everybody else at the workplace, but if you want to keep your job, you may want to consider taking this medicine that may just actually make you more relaxed. And then going back to Dr. Torrey's example, many years later the person says, I know you think I'm schizophrenic, but to some degree there's some sort of acknowledged compliance that goes along with it. And then for others, the criminal justice system does work. A judge can say, you know, look, you don't have to be locked up. But if you're not compliant, well, that's what's going to happen. And that's certainly what manifests in the insanity equity system, that if people violate order of conditions, they go back into a custodial environment. And then finally, for those who are of age, who are adult, there's the prospect of homelessness. There's, hey, look, you know, you're in your 30s. I am supporting you. I don't have to support you. You have to consider whether this lifestyle that you have where you are comfortable is something that's entitled to you if you don't take your medicines. You have responsibilities in this just as I love you. So that's something that each family finds on their own. I can tell you from not only professional experience as treatment, but I have had chronic mental illness in my family. I have also buried a sibling with psychiatric illness, and I know not only the futility but the lessons learned thereof. I can tell you that if you learn your leverage and you use it right in a sensitive, loving relationship, then you get enduring compliance, and that's the holy grail here.
Mr. Fitzpatrick, you want to comment on this?
Yeah, just quickly, thank you, Mr. Chairman. You know, early identification, intervention in schools and primary care offices, where families and children are, I think is something we need to explore. It's sort of the norm, as Dr. Insole said. You know, there are a package of services or treatments available out there that if you could make them available in virtually all communities, it would really make a difference. And they include sort of treatment teams, crisis stabilization programs, supported housing, supported employment programs, for children, certainly cognitive behavioral therapy, as Dr. Kopowitz talked about earlier, behavior therapy and other interventions that absolutely make a difference. The challenge we have, and we saw this in our 2009 Grading the States report, it's hit or miss. You can go from one county to the next. In one county those services exist, the next county they don't. The recession comes, it wipes out services, long waiting lists. It takes families sometimes years and years and years to find the services they need. But we know what works now. We're not there. We don't have treatment, the cure, serious mental illness, but we know what the road to recovery is for most of the people with serious mental illness. And we also know that there are people, obviously, that lack insight, and we've had that conversation, and that's a different path.
Dr. Kopowitz?
To answer what works, there's some projects that are really quite impressive. There's one called the Massachusetts Child Psychiatry Access Project. So here you have pediatricians across the state of Massachusetts who get stuck with a patient who has a psychiatric problem in their pediatric practice. And they are able to get telephonic consultation within that day as to how to help. So it becomes a safety net not only for the patient, but for the pediatricians. And they've proven in this project that the pediatricians feel better able to take care of these kids, understand what kind of interventions they should do, and know when they should reach for something more comprehensive, like a hospitalization or a psychiatric consultation. So models like that, that was developed, by the way, during Governor Romney's term, and by a child psychiatrist named Ron Steingart, who's now a colleague at the Child Mind Institute, are effective. And they take resources and say we can make the people there better than they are before because we give them more knowledge and they take care, and they're the first line of attack. If pediatricians could really become better at identifying those warning signs, those unusual behaviors, that's who parents turn to first.
I think we're going to go to Ms. Elmers of North Carolina, who's also a nurse.
To thank this panel, and this is a very, very powerful discussion that we're having here. And I do want to go back to the issue of HIPAA, because that is something at the federal level that we can intervene. And I think one of the points, or one of the clarifications that I wanted to make, Mr. Chairman, was you had mentioned that even HHS in some instances uses HIPAA as, and I'm going to say excuse, or relies on misinformation that's related. Is that correct? I mean, was that one of the things that we were talking about when we were talking about in relation to mental health? Is that because I know we've talked about doctors who, unfortunately, many times, rely back on HIPAA and say, well, I'm sorry, it's because of HIPAA that I cannot do this. And I would also like to say there that I think a lot of times it is the fear of legal action against a physician, and because HIPAA is difficult to understand, and I think that it's something that that may just be an easy out, so to speak. And I know that doesn't seem reasonable, especially in the seriousness of these issues, but I unfortunately think that sometimes that is what happens. In North Carolina, we need more mental health beds. There is no doubt about it. I have visited emergency room after emergency room where they are sometimes treating mental illness patients who are dangerous to themselves and others in the emergency rooms where they have had to make accommodations. And these are not individuals, the healthcare professionals there are not qualified to take care of them as mental health patients. They do not have psychiatric background, but they are doing the best job that they possibly can in the circumstance. So I also want to be very helpful in that area. But Mr. Malam, I do want to go back to one point, because you had talked about having private health care insurance. And one of the main points was, medication, maybe being admitted and being treated for 5 days, but that sometimes it takes 5 weeks for medication to actually start taking effect. In your experience, in the experience you had with your son, what could you have seen done better, or as far as insurance coverage, was there a cutoff of days of treatment? Was there something that could have been done better there? Because I think that's another place that we might be able to help.
Yeah, these are going to be strong words, but one of my major problems, I consider the medical community and the healthcare community to almost be in a collusion or a conspiracy to at the adverse for the patient. In my son's situation, it was always, well, the insurance company's going to approve 5 days. And somehow my son was always well by 5 days. Even like last time when I told him my son was still seeing invisible policemen wearing raincoats. They said they didn't see it, let him go. So there's no doubt in my mind that there is, and it may be what we have to live with, okay? But certainly the doctors looked, and actually it's in the medical record, the day he got in there, it says clearly in the charts, we're charting him for discharge. That's from day one. Yeah. He wasn't ready. One other thing I had mentioned is the Joint Accreditation, I think, committee only tracks suicide for 2 days after people are released. I just don't see we track what we're doing. My son, they all knew my son wasn't going to take his medication. He had told them, it's in the medical records, he told them he wasn't going to take the medication. So in answer to the question, I don't know what could be doing better, but there had to be some mechanism whereby, now, as I mentioned, my father-in-law is an attorney in Louisiana. He said it's pretty simple. Most of these young men are in trouble with the law. We could make it part of the bond. So it wouldn't be on the government. It would be part of your bond. You're out. You got to go take a drug test 2 days to make sure you're not doing illegal drugs and you are taking your medicines. I believe California has a law like that, that every 2 days you have to check in and take care of your medicine. We need to do something proactive to make sure that person that, even if he doesn't want to take his medicine, takes his medicine. Yeah.
Thank you. I really appreciate this, Mr. Chairman, having this particular discussion. Again, very, very powerful.
Thank you, Mr. Chairman. I want to ask a question here of the panel, too, in some ways, and it's continuing to follow up Ms. Kasser's comments and some of our families. But a couple weeks ago when we had a meeting, Dr. Burgess brought up a question about biomarkers. Interestingly enough, Lancet last week published an article saying they actually found a connection between 5 different severe mental illnesses: severe depression, autism spectrum disorder, bipolar, attention deficit disorder, and schizophrenia. And they actually found these on chromosomes 3 and another part of chromosome 10. I guess there was 4 places in the genome. They studied 33,000 psychiatric patients and 28,000 people without mental disorder. As we're going through this, and I'm back to the purpose of why we're here. We're trying to help identify people early on. What can we do? Prevent tragedies again. Dr. Insole, you got an NIMH there.
Well, so that's our study. I'm very proud that we got this far, but I need to make sure you understand that that's still at the very beginning of trying to provide the genetic architecture for any of these disorders. And in some ways, the glass is really half empty, because the other part of that was it didn't provide a biomarker for any specific disorder. In fact, the same genetic markers crossed over all of the disorders that people were looking for. But your general point, Mr. Chairman, is right on the mark, that in the rest of medicine, where we've had the most progress is with early detection, early intervention. We don't wait for the heart attack before we treat people with heart disease. In fact, we try to make sure people don't have the heart attack. In the case of brain disorders, behavioral change is a late event. It's always a late event. By the time you have a psychotic event, you've had your brain changing for years, for a long time, and we don't know it. So how do we identify that? And one of the highest priorities for us at NIMH is developing the biomarkers that allow you to detect this years before the behavior becomes the issue that you have to contend with. Because what we've learned from cancer and cardiology and now AIDS is that that's when you get the best outcomes. You get there early. You don't wait for the heart attack to try to intervene.
And I think the important part for us to remember is that this is very possible. In today's Times, there's an editorial about a baby who might have been cured of AIDS. 10 years ago, we would say that was impossible. And with the kind of funding, the kind of scientific rigor that we applied to the AIDS epidemic and now to the treatment of AIDS, we can actually start to think cautiously about the fact that we could cure AIDS. So that while the glass may still be half empty, the fact is that between the genetics and between resting brain state and neuroimaging and a whole bunch of different ways we could look at the brain, we can get to the point where we can start to identify kids, or mostly it'll be kids or young adults, before the first episode.
Thank you. I'm going to ask each person here to give kind of closing 1-minute statement as we go through this. I'm going to start with Dr. Burgess and then Ms. Castor, as we're kind of wrapping up here. So, Dr. Burgess.
I want to use my time for a closing statement to ask one follow-up question.
You could do that, too.
And I appreciate everyone's put a lot of time into this today, and this has been great. Dr. Wellner, you outlined 3 things where you said these are the cardinal signs, the sine qua non of someone who's going to be in real trouble or cause real trouble to society. And I've got a list here, and it's by no means exhaustive, and in fact it leaves off the 3 most notorious mass killings of recently, but going back 15 years, there's 25, and they all seem to have a common thread, and the common thread is treatment with some type of antidepressant. Now, I don't raise this to say there's a nexus here, but what it does strike me is that every one of these individuals had accessed our mental health system and received a therapy, whether or not it was the right therapy or whether it was enough or whether they were taking it. Those are all questions that we're going to have to struggle with. But it doesn't look like there's a lack of identification of these individuals. In fact, they've all been in front of a psychologist or psychiatrist or a school nurse and received prescriptive medicine for their condition. Since we know your critical indicators and they're coming to someone in the system, how do we improve that track record?
I ain't giving up a minute to answer this, but I'll answer it fast. I'd be interested to know what Dr. Koplowitz has to say about what I'm about to say, and that is, I think that for a time, the psychopharmacologic approach to an adolescent who is struggling, this is a lot harder to untangle the puzzle of what's going on in an adolescent. Illnesses are just starting. They're going through changes. Are we seeing depression? Are we seeing psychosis? Are we seeing oppositional defiance? And so a lot of prescribing practices for people who are struggling for a long time relied presumptively on antidepressants because they were safe, because they would diminish anxiety, because they would diminish agitation. Now, of course, if you give someone a medicine that can cause them agitation at a time when they are turbulent enough to have violent urges, well, that's a pretty lethal cocktail. So are you speaking of, is that history reflective of prescribing practices or the diagnosis itself? Is that reflective of the effect or side effect of a medication in someone who has behavioral problems that the mental health professional is obliged not to say he's personality disordered? You're obliged as a mental health professional to say, here's a patient in my office. Let me presume there's something treatable. So you have a number of different forces that relate to prescribing practices, to the uncertainty of diagnosis at a time, as well as what happens if you give something that can be agitating and it agitates the wrong person at the wrong time.
Well, and I appreciate that, but the broader point is these are all individuals who've come before our mental health system over the last 15 years.
You just made my point, that people are crawling into the cracks, not all of them, but Baumhammers in Pittsburgh, and Taylor in Pittsburgh, and Uyasugi in Hawaii, and Crumpley in New York. And these are people I've met and I've interviewed, and they had people concerned about them. In many cases, they had loving families. Baumhammers was living at home. He even came by your office. I mean, these are people who did not necessarily fall through the cracks. And this gets back to the ACT discussion that we had before. It doesn't mean that some of them don't encounter ineffectual systems, but there are different forces.
But Dr. Burgess, I think there's an issue here that, first of all, diagnosis in psychiatry is a clinical diagnosis. It's, you're having chest pain, it's radiating down your left arm, we presume you're having a heart attack. But we can do blood tests. We can do EKGs. We don't have that in psychiatry. So it can't be done in 7 minutes. It has to be, it takes a while. It takes most people to do a diagnostic evaluation several hours. You need multiple informants. You need to hear from the parents. You have to hear from the school as to what the report is going on. And you want to see a change in behavior. The other big issue that we have found is that many times you can prescribe a medication and the medication isn't taken. In fact, we hear today from parents who they may have even gotten the right diagnosis, the right pill, and yet the patient just is not going to take the pills. Now, as far as SSRIs go, you know, SSRIs came out into this country, and the overwhelming majority of people who were giving them were non-psychiatrists. And the reason for that was we finally had an antidepressant that didn't kill people. So if you took Tofranil and Elavil, you had cardiotoxicity. People were petrified of those, that kids accidentally took their mother's antidepressants. You know, they found them in the medicine chest, little toddlers, and they got cardiac side effects. So in the beginning, it was given out, and remember, it only came in one size. Prozac came in 20 milligrams. But I think the important part is we shouldn't throw out the baby with the bathwater. There's also evidence that once Prozac came out and those drugs came out, the suicide rates in white males actually went down by 18%. And once we put the warning label on and primary care physicians got nervous about prescribing, the suicide rate went back up by 18% in that particularly very dangerous group. White males are most successful at killing themselves versus anybody else. So I think it's, A, diagnosis is complicated, it takes time, it takes training, and B, the fact that almost all kids, teenagers and young adults don't want to take pills, so that it's an ongoing conversation. I'm sorry, Tom, you?
Yeah, I just think that in terms of where we're ending up here, I don't think your statement should go unchallenged in any way. I'm not sure anybody has very good evidence that all of the mass shootings or many of the violent events that we're talking about are linked together by SSRI use. If that's the case, I haven't seen those data. It's a little bit like what we were talking about before with respect to the commitment laws. There are people who are on both sides of this, and clearly in the case of treatments, there are many people in this community who are against any medication use at all. And it's in a polarized argument like that, you're probably safest to try to find yourself in the middle somewhere.
I wasn't trying to draw the nexus, but the only point is these are all people who had been in front of your profession at some point.
But Tom has you talked about this last time, that most of the people who you found who were the most dangerous were people who were taking medicine who stopped, and people who stopped their treatment. That there was a group of people who had psychosis. They were very, very ill, and they stopped taking their medicine. And that's when, am I quoting you correctly?
No, I think that's fair, and your basic point, Dr. Burgess, I wouldn't disagree with. There is an issue that many of these people, because what you'll hear is that the real problem is stigma, nobody wants to go for treatment. Reality is many of these people have been assessed, and many of them have been prescribed or been evaluated and referred for additional kinds of treatments. That's true for both suicide and homicide. So we do have an issue with respect to the effectiveness of what we're doing.
Dr. Torrey.
You know, we're talking about the mass killings. The data would suggest that 50% of them are associated with untreated severe mental illness. Dr. Wellner was referring to a broader group also that do not necessarily have a severe mental illness. Of those with a severe mental illness, it's quite clear in retrospect that they were identified. The question that I think is most important is why were they not referred for treatment? And I refer to Cho at Virginia Tech, to Loeffner at Tucson. Loeffner was even diagnosed with schizophrenia by one of his internet friends on it. I would say the same thing about James Holmes in Aurora. Why wasn't that carried forward? And it has to do with a lot of things, including the fear of being sued, including the fact that the state laws did not allow it. But the fact is, if we don't address that critical issue, we're going to be back here in 6 months or 6 weeks, because these are going to continue to happen unless we get people who are potentially dangerous and identifiable into treatment. Most are not riding under the radar. Most of them are very clear. They look like Goodyear blimps with trailing signs saying, I need treatment, but we're not getting them to treatment.
All right, thank you. Ms. Castro, you want to give any closing?
Yes, in closing, I'd like to thank you again, Mr. Chairman, for organizing this outstanding hearing. And in addition to the early diagnosis and treatment, I do think that all of the evidence suggests we've got to continue to invest in brain research. And the example, Dr. Kopowitz, you gave of this recent fabulous news of curing AIDS in an infant, that has only come about because of a sustained commitment through Ryan White and through our communities and researchers and the Congress in providing the resources to get to that point. And I think it's obvious now that we need to do more in brain research, whether it's Alzheimer's, because of the growing baby boom population, and these outrageous statistics of suicides and mental illness. I think it's a call to action. I'm glad the Obama administration appears to be considering this, but I think the Congress can do a great deal working together in a bipartisan way, pushing that forward. Thank you.
Thank you. Now, if Liza Long is still with us, I'd like to see if you would like to make a closing minute of statements.
Thank you so much, Chairman Murphy, for having this public forum. I feel like I've learned so much from all the other panelists today, and I'm really grateful for you for opening up this dialogue, because it's dialogue like this that will reduce stigma and increase access to treatment for millions of American children and their families. I was struck by Dr. Insole's repeated comparisons to diabetes, a physical chronic condition. I feel like if we can learn to diagnose mental illness early and then manage it like a chronic condition, we'll hear lots more stories like Pete Earley's. And I think that's what every parent wants for his or her son or daughter who struggles with a mental disorder, that they can live happy, productive lives and be happy, fulfilled members of society. Thank you.
Thank you very much. Each person will allow you to talk first.
Sure.
If there's closing comments.
I'd like to continue just what Liza said. First of all, thank you. I've told you before, you're my hero. I think we should have more psychologists and maybe more child psychiatrists in the Congress. But you are the example for us of bringing something that is essential. And I think it's an essential national conversation. It's not just one hearing or two hearings. It's the fact that every family, some way in America, has been touched. And it's time to speak up for kids. If 75% of most of the serious psychiatric illness occurs before 24 and 50% before 14, then we have to consider annual mental health checkups. The only way you can do that is that pediatricians have to get better at understanding the warning signs. I think we also have to do a better job at educating new teachers and even teachers who are currently teaching so that they don't avoid the weird, the quiet, the socially isolated kid and just hope that they go away, but that they feel that there's some tools to be able to identify them and to go to the school guidance counselor or the school psychologist to get help before there's some kind of violence. So if the message should be that these are as real, as common, and as treatable as physical illness, and that they deserve the same kind of scientific rigor, which means more investment in pediatric neuroscience and in brain science, and they deserve the same kind of compassion we give when we see someone in a wheelchair, and they're as treatable as difficult illnesses like AIDS and like cancer.
Thank you. Mr. Fitzpatrick?
Thank you, Mr. Chairman. These are very important hearings. I look forward to the future hearings that this committee will conduct. Absolutely, we need to have more research, brain research. I think we're on the verge of a very exciting discovery, and we're not where we need to be yet, but this is essential. Stigma stops people from getting treatment. These need to be community conversations. Change happens in local communities, and we need to engage it as we have on other illnesses and other problems in this country, and have these to be larger community conversations. This hearing for me is all about access, giving access to treatment, to diagnose treatment and support for people with serious mental illness in their families, and I think there are a number of issues we need to look at in terms of the laws, particularly state laws that block access. Better, tighter, more diligent system that pays attention to where people don't get lost. Again, only 40% of the people in this country with serious mental illness on a given day have access to treatment. That's stunning. That's appalling. We don't have a single coordinated system. I think the Affordable Care Act gives us opportunities. I think when the final Parity regulations are finally released by HHS, it'll give us a signal on the impact of the Affordable Care Act on serious mental illness, because the parity language is written all through the Affordable Care Act. I will echo what I said before. The effective treatment does exist, but it's in pockets around the country. And we need to spread that treatment and what really is effective to communities across the country. Again, back to my notion of community dialogues. And then lastly, it's really about early intervention, early engagement, getting in there early, not having families wait years and years and years, sort of bouncing around a system that sometimes isn't very welcoming. And we need to take a look at that. Thank you, Mr. Chairman.
Thank you. Mr. Earley, closing comment there.
Thank you very much for, Thank you for having these hearings. You know, because of Newtown, I think we're finally reaching a tipping point. Everybody wants to do something. We have to take action. I would urge you to be very thoughtful and careful about what actions we take. In Virginia, after the Virginia Tech shooting, there were a flurry of bills. Virginia now is one of the leading states about reporting anyone with a mental illness to various federal agencies, even people who have shown no danger, people who have just simply shown up and said, gee, I need help. I need help in the hospital. We talked about stigma. When you make lists like this, you are creating stigma. You are saying these people are different. They're dangerous. We have to have a list of them. You have to be very careful about that. I read that 40% of the first responders after 9/11 suffered from some form of PTSD. What about the officer who's getting a divorce, who wants to go see a psychiatrist because he's having trouble dealing with it? Are you going to say to him, he's different, we need to put him in a list, we need to start banning him? You have to remember, we are your brothers, your sisters. We are Patrick Kennedy. We are Terry Bradshaw. We are not the enemy.
Thank you, Mr. Earley. Mr. Milam.
Yes, sir. Thank you, Mr. Chairman, for having these meetings. My wife, Debbie, and I greatly appreciate the opportunity to speak before you. And lastly, I would just say a final thought from me. My son was a great kid, a fun-loving young man, looked fabulous if you saw him earlier, and through his demise. And I lay awake at night, I can tell you every night, thinking, what more could a parent do? And I appreciate this committee trying to work towards what more can we do, because the horrors that my son had to go through to worry about people coming to get him from outer space and things like that. That's just got to be a painful, agonizing way to live, and I thank you for this opportunity.
I would pick up on the model of heart disease to say that culture matters, that we now have a national imperative against obesity because we've understood that eating habits have some impact on actual physical illness. Well, I will tell you that our fascination and our indoctrination of a culture of young people with violence through entertainment media that are polluting the culture of this United States has to be dealt with the same way we've dealt with the tobacco industry, or the convergence of this poison, and it is a poison, on the developing minds and vulnerability is the last thing a paranoid individual who is alienated and isolated needs. Culture matters in mental illness, just as it matters in physical illness, and I do believe that culture has to be part of the solution here.
And Dr. Torrey.
Mr. Chairman, we're all obligated to you for this, and we appreciate it very much. The future belongs to Dr. Insole and NIMH, and I will just add Dr. Insole is the best NIMH director we've had. I've known all of them except the very first one, and he has been the first one to really focus on the issue of severe mental illness. So that's where the future is. But in the meantime, we have a large number of severely mentally ill individuals out there in the community who are asking for help. We are not doing a good job of getting them to treatment either voluntarily or involuntarily. And as long as we're failing at this, we are going to continue to see the Auroras, we're going to continue to see the Tucsons, we're going to continue to see the Newtowns, and until something changes, absolutely it's going to continue.
Thank you. Dr. Insole.
Let me just finish again by thanking the parents, Mr. Milam and Mr. Earley and Ms. Long, for joining us and sharing. I know how difficult this is. It's difficult to listen to, and it's incredibly important for us all to hear the message you have to send. I think if I were going to summarize, we've heard a lot about the need for access, changing policies, some about the need for better science, which I certainly would support. But maybe most of all, I think the unspoken message here is the need for leadership in this area. You started off, Mr. Chairman, by saying that we've had blinders on. And I couldn't help but think of the message that President Kennedy gave to Congress 50 years ago, last month, in which he said, this neglect has gone on too long. And here we are 50 years later, still with blinders on. So let me thank you for beginning this process. Let's hope that this is a journey. We'd like to continue with you as you show your leadership in this area. It certainly is greatly needed. And everything that we can do to help you as you make us take our blinders off, we'll be there to serve.
Thank you, Dr. Insole. I want to thank all the panelists. Your stories were very moving, compassionate, and sadly they were true. And thank the members who and my colleagues who were here also. This is a very valuable discussion, and we wanted this to be in a different direction to start off with. We'll do some other hearings more targeted towards what we can be doing as Congress to move forward in this. And I think it helped members to understand, put a face on mental illness and the families, understand the fears, the worries, the love, the frustration, telling us we need, in fact, we must. It is our obligation as elected officials to continue to pursue this. It is a public health and public safety issue, and it is within the realm, I think, of looking at promoting the general welfare of our country. It is also important to know from those who are here or those who are watching, over the years we have developed effective evidence-based treatments. Mental health, mental illness treatment is not where it was 100 years ago or even 50 years ago. A lot of change has taken place even since President Kennedy made those remarks on our challenges. We have had major changes in the value of prescription medication, but we still have a long way to go in terms of being able to target that towards individuals. We obviously will have to go further with reviewing federal laws, state laws, which actually impair actions we can take, and we're going to have to look at those. And we have certainly a long way to go with our research, and we hope you can continue those areas. I want to say that, and I also thank several staff who've been behind the scenes working this. They've been very thorough, and we're going to continue to work them on this. But it's because we all know we are committed to this, and we know it has to be continuous, unwavering, and thoughtful in our approach. I want to make sure we're not simply doing some knee-jerk actions and think because we did something, we did the right thing. The worst we could do is lull ourselves back into some state of sleep and saying, well, we took care of mental illness, so we're done for the next decade. And I don't think either side of the aisle would be satisfied with that at all. To the parents, thank you. Have hope. Don't give up. We hear you, and we'll be with you. Thank you very much.